So, hello, good morning, good evening, friends. And we had, after the struggles of long of months of struggles, the exam has happened. And I myself has written the exam. So, I will, like neurology paper I have written to know how the pattern will be. So, we will start review about NEET SS 2021, the neurology part. And for me, the analysis which I have to tell, like after seeing the paper, was like, even though in the medicine part, for especially for those who are written for nephro, rheumatology, and endocrinology, there is a lot of neurology questions, and these neurology questions were like core neurology. It looks a lot of concepts, and it is actually not from Harrison. None of the questions I felt was not from Harrison and neuro side, and most questions required practical conceptual level of knowledge. So a lot of core neuro questions which requires in-depth knowledge, and there were core neurosurgery questions also came, like management, but it is still fewer we will go and discuss, and most of the questions were lengthy. There were no direct questions. I could not find out any direct questions at all in neurology. And all the questions were lengthy and clinical questions, and it was like a case scenario and what will you do next. For that, you need to know the latest guidelines, and you need to know the conceptual level knowledge is very important. And the time management for me was very, very difficult. For those who are writing the exam, after reading that huge questions, I felt that time management will be a major problem. And especially those who are not preparing for neuro. For them also, the medicine part, there are a lot of questions has come up from neurology, and those questions asked were in high standards. So I felt it is not good for a non-neuro student who was preparing for non-neuro subject to ask that much high-level neuro. And the high-level neuro questions were also nothing was from Harrison. Everything was very practical questions, very clinical questions. But even if with all these negatives, what I noticed that in every questions, even though it was it was tough for you, when you read the question, you will feel like it is tough question. And many questions were image-based questions, and those image-based questions actually, most of the questions doesn't need the image, because in the history or in the question directly they had given some clues, and most of these clues were clinical clues. So I will when I go through the questions, I will tell you that what was a keyword in each question. Some questions were rather direct, and some questions were having keywords. So those keywords the keywords are important thing. That is a major part which will tell you to arrive at the answer, which will help you to arrive at the answer. And most of the image-based questions doesn't needed the image, because from the history line only you can able to answer it. If you catch all of that critical point of the question. And altogether, I felt the question was not the entire paper was not easy. It was tough, and it was a bit higher level than previous NEET. And it was in the neuro side, almost every questions were not from Harrison, and it were like bit very high level. But still, I felt it might be answerable. Many questions were answerable if you have some clinical pattern of knowledge or conceptual knowledge is there. And if you catch all of the important point from the question, it may be answerable. And but I still think that the cutoff may come down this time, not like last time. The cutoff will be less, and so you cannot predict what the rank will be. The tougher the question goes, the cutoff will be comes down. So with that, we will go to the question that which I could recollect was 70 questions with the help of others, as well as the questions I came. And 70 questions, I got few questions which are not asked in the neurology paper, but in other papers. But most of the questions were asked in the neurology questions. Like out of the 100, around 16 and 70 questions from core neurology. And when you divide into portion ways, there are 10 major portion. I divided the entire question into 10 major portion. As in any exam, you will see that stroke and vascular, which consume the major part of neurology question. Here also same. There are 12 questions in the stroke, and all the questions were very clinical, and all were very practical oriented, and all were like scenarios, and what will you do next? What is the management? That sort of questions were there. And there are few questions which came from the neurosurgery part also. And in peripheral nerve, muscle, NMJ and genetics I clubbed together, because genetic oriented questions most were related to peripheral nerve or peripheral nervous system. So there are 14 questions together in that bundle. And in movement disorder ataxia, there were around 10 questions. 1 was from ataxia, remaining 9 from movement disorder. That also were like core movement disorder questions. Demyelination, there were 6 questions, but in the demyelination, they have not asked a single question from MS. All the questions were from non-MS demyelination, which actually I was expecting that to happen. At least some few questions will come from non-MS. That was my expectation actually. I have told in the review also, like many preparations and all, I had told that non-MS there is likelihood of asking non-MS questions. And the spinal cord, there are 2 questions. Neuro-ophthalmology, actually pure neuro-ophthalmology 3 questions, but all the demyelination 6 questions had some neuro-ophthalm in that. Papillitis or something was there, they're telling. And infection, there are 6 questions in neurology paper and 1 question was asked in a non-neuro paper. I think in nephrology paper. That actually I got from one of my student. And dementia, there were 8 questions from dementia. So individually after a stroke, if you take it, after stroke and movement disorder, the next biggest area was from dementia. Then epilepsy, I was expecting many questions, but only 2 questions came. Both were EEG based, both were answerable questions. And there were some questions from miscellaneous and 1 question from sleep. Altogether, I could recollect around 70 questions. This was a division of question. We will go in this order. First, we will see the stroke questions. So there are 12 questions asked on the stroke and vascular. The first question was the patient. These questions may not be the exact question which is asked in the exam. This is a stem of the question will be same. And options, some questions I got all the options. Some I could not recollect all the options because I felt like the questions are very lengthy. So it was actually difficult for even me to memorize it because I was sitting in the hall and trying to memorize it. And the first question was patient with a history of old stroke on aspirin and atorvastatin. MRS score was given, I think was like 1, and now presented with weakness of the left side of the body, and which completely improved within 2 days back. An angiogram is shown below. What will you do next? That was a question. So it is actually rather an easy question, even though it was given an angiogram and all. You can see that the stenosis here, and you can see the, I have told in our videos, like when you are discussing about multiple angiograms, we have discussed lot of angiogram images in our stroke module. In that I have told that you can identify the common carotid, which divides in internal and external carotid. I mean, this is external carotid and this is internal carotid. Internal carotid goes laterally, then comes medially and make an S-shaped turn. So you can see that it comes and goes like this. For the external carotid, you can see multiple branches. I have told how to differentiate external carotid and internal carotid in that module. So you can see is a internal carotid artery at the just above the bifurcation. There is a tight stenosis. There's a tight stenosis. What you can see is a tight stenosis there. Okay. So the question is in fact a patient with completely recovered. So it can be either a minor stroke or TAA. So MRS score is good, less than 1 only, 0 to 1 only. So good MRS score. And with a completely recovered TAA, what will you do next? The options are carotid stenting, antiplatelets and statin, anticoagulation, dual antiplatelets. So it is an extracranial in the ICA, extracranial ICA. I have discussed that extracranial and intracranial ICAD. I have discussed about ICAD in our modules. ICAD requires dual antiplatelets. For ICA, extracranial, it requires either a carotid artery stenting or a carotid endarterectomy. That we have discussed in the module. So the answer is not antiplatelets and statin. That you have to start, of course, but the exact treatment is not that. Then anticoagulation has no role, and dual antiplatelets has a role only in ICAD, intracranial atherosclerotic disease. This is an extracranial carotid artery. The carotid artery can be extracranial and intracranial. Intracranial is from the Peter segment. All those things we have discussed in the modules. What is a different division of carotid artery? Also, both layers classification. All those things we have discussed in our modules. You can go through that. So this is the question is basically what will you do for a treatment for in ICS stenosis, extracranial ICS stenosis presenting with stroke. So we have the answer is a carotid artery stenting. We have discussed it in our module. This is the same slide from our module where we have discussed that symptomatic carotid artery extracranial. I had mentioned it. Less than 6 months from the symptomatic patient. If the stenosis is more than 50%, you go with carotid endarterectomy is the ideal treatment if the stroke or death risk is less than 6%. But in the options you see there is no carotid artery stenting was given, endarterectomy was not given. So if it is asymptomatic, more than 60% stenosis, again carotid endarterectomy is the treatment. And the second option is carotid artery stenting. So basically carotid artery disease is with extracranial, symptomatic, if the stenosis is more than 50%, go with carotid endarterectomy. First line. Or if carotid endarterectomy is not able to do, the second line option is carotid artery stenting, CAS. Okay, CAS is second line option, not the first line option. Carotid endarterectomy is a first line option. If in asymptomatic also, if the stenosis is above 60% and the preoperative stroke risk is less than 3%, here it is less than 6%. You should go with carotid endarterectomy. So, symptomatic less than 6 months, class 1 evidence, the best evidence is for endarterectomy, class 2A is for carotid artery stenting. Again, asymptomatic also similar way, the class 2A is carotid endarterectomy, only class 2B is carotid artery stenting. But in the question, there was only one option was given, there was no endarterectomy, it was only stenting was option, so the answer is stenting. So basically, a carotid artery disease, if it is extracranial, symptomatic more than 50%, go with carotid endarterectomy or stenting. Preferred is carotid endarterectomy. But if it is not able to do carotid endarterectomy or if there is a contraindication, go with carotid artery stenting. If it is asymptomatic, more than 60%, again go with the same direction. Go first line with carotid endarterectomy. If it is not possible, go with carotid artery stenting. The next question also was regarding the same similar carotid artery stenosis only. A 75-year-old male presented with diabetic, otherwise well, and again the patient was otherwise normal, and patient presents right-sided weakness on MRI showing a thalamic infarct. An angiogram showing a tandem plaque on the bifurcation with a 78% stenosis. What is the next step of management? Again, here the catchword is a long tandem plaque. That is a catchword here. So, and again one more thing is age of the patient. I think it was 75 years. That is what I remember. It was 75 years was given. Because these two are keywords. So, you think either the option is carotid artery stenting or carotid endarterectomy, CEA or CAS. These are two options available. This is symptomatic again. Symptomatic carotid artery disease, and there is a preserved areas there. Even though carotid artery is entirely occluded, 78% occluded, you have only a small infarct on the left capsulothalamic area. So, both these are options. So, thrombolysis is never an option, and antiplatelets and statins are not an option because time window, all those things are not given. Antiplatelets and statins obviously you have to give, but the exact treatment is not this, either stenting or endarterectomy. So, what will you go for? So, again, we have discussed in the module about the high risk for carotid endarterectomy. High risk factors. There are physiological high risk factors which includes age more than or equal to 75. Here the patient's age was 75. So that is high risk factor. Then CAD, coronary artery disease, where with 2 or more vessels, unstable angina, myocardial infarction. Because in carotid endarterectomy, there is risk of MI is higher. While those with stenting, risk of post-procedure stroke is higher. Stroke is higher for stenting and MI is higher for endarterectomy. So, these are the high risk factor, ejection fraction less than 30%, CKD or COPD. In physiologically. Again, anatomically, other high risk factors includes anatomical high risk factors, high riding or bifurcation above C2 or below clavicle, or previous cervical radiation or dissection, or a tandem stenosis. This was a catchword in our question. Bilateral carotid artery disease, contralateral carotid occlusions, or recurrent. All those things we have discussed in our module. This is the same slide from the module where I am discussing about in secondary stroke prevention. The module in the module of stroke, the chapter about secondary stroke prevention. So here in this question, the catchword is more than 75 and long tandem plaque. Tandem plaque means a carotid artery disease which has stenosis here in the lower level, and there is one more stenosis in the higher level, anywhere in the higher level, 2 stenosis, that is known as tandem occlusion. Here is a long plaque which causes tandem occlusion, one occlusion below and one occlusion above. So when there is a 2 occlusion or a tandem occlusion, or the age more than 75, or a cardiac comorbidity, or a COPD or CKD, or some anatomical risk factors are there, you cannot go with carotid endarterectomy. So the answer again here is stenting. So both the options, one question was there, the tight stenosis, but in the option they are not given endarterectomy. So the answer was stenting. Here endarterectomy as well as stenting, both options are given, but the age was more than 75 and there's a long tandem plaque. Both are risk factors for a endarterectomy. So you should go with stenting. So that was the second question. Again, it was very tricky and very practical clinical question. The next question was again a patient with a non-case of AF with an MRS score of 1, presented with mild motor aphasia and right hemiparesis. And NIHS score was 3, aspect score was 8, presented within 5 hours of onset, and angio shows MCA occlusion with a good collaterals. And what will you do next? That was again a very practical, very practical question, and it requires the knowledge about the recent update of ACAHS stroke management. Again, the same thing we had discussed in detail in the mechanical thrombectomy session in our module on mechanical thrombectomy endovascular therapy in stroke module. The options were thrombolysis, thrombectomy, perfusion image, then plan for thrombectomy, conservative management. These are the 4 options given. So the first keyword is 5 hours. So 5 hours means thrombolysis is there for less than 4.5 hours. So that is not the answer. That is omissed out. So next option remaining is thrombectomy because he has a MC occlusion is there. And perfusion image is required or not. Again, we have discussed that if the patient is less than 6 hours of onset of stroke, no higher images are required. Perfusion image or CT perfusion, all those things are not required. This also we have rightly, I have told in the our module, if the patient comes within 6 hours, no perfusion scan or nothing is required. You can take directly for thrombectomy. Okay, so that is the perfusion image is anyway not required. Then plan for thrombectomy is not the option. So remaining is either thrombectomy or a conservative management. But most I think most of you will go for thrombectomy because there is a stroke with hemiparesis and mild aphasia, and you are within window period 5 hours of within 6 hours of onset, you will go for thrombectomy. Might be the option or answer you might have thought. But again, the next keyword is NIHS. That is what I told. All the questions they are given 1 or 2 keywords. Aspect score also we have discussed. NIHS score also we have discussed. Aspect score less than 6 is a relative contraindication, more than 6 is indication for thrombectomy. But you see the same we have discussed in the mechanical thrombectomy indications. Level 1A evidence was given for age more than 13, pre-stroke MRS 0 to 1. Again, here given MRS 1, so it is good. And IC or MCA M1 segment that is there. But NIHS score more than 6, aspect score more than 6, groin puncture within 6 hours. That means a minor stroke with NIHS less than 3, according to the guidelines, doesn't have level 1A evidence, it has level 2B evidence only. Okay, so what is 1A and 2B? 2B means a weak association and weak evidence is there, may be reasonable, may be considered. Again, there is a minor stroke, there is no definite guidelines for a thrombectomy within 6 hours. So I think the better option will be a conservative management. Because there is a minor stroke, even though within 6 hours, patient has a very good collaterals. That is why they are mentioned about very good collaterals. That about collaterals also we have discussed in our module, primary collateral, secondary collateral, tertiary collaterals, and what is the importance of collateral. When collaterals are very good, there is a minor stroke with a very NIHS less than 13, less than 3, you can go with a conservative management. That is what I think is a better option. But again, it is a very purely practical question. There may be some ambiguity whether to go for thrombectomy or conservative management. But according to the guidelines available, whatever options we can give is a conservative management. Again, I felt this question is a little bit ambiguous question. There is confusion between 2 options. I think the best option is a conservative management because NIHS is less than 6 as well as a very good collaterals. Okay, that is the reason. So that was the answer of that question. Now comes the next question. A patient comes of complaints of left side ptosis, right side weakness and history of headache and neck pain 1 day prior to it. Angiogram is given below, shown what? Actually, this question doesn't require angiogram. I'll directly tell the answer because there is a question that the left ptosis and right side weakness. Right side weakness means left hemispheric involvement. So patient has a left hemispheric involvement and left ptosis. So unilateral ptosis. That means sympathetic is involved. So likely cause is either a carotid or the sympathetic tracts come from the thalamus, hypothalamic area, then descend downwards to the carotid, then comes upward to the external carotid, that goes like that. So anywhere in the sympathetic pathway there is a damage. So there is a stroke on left side with the right ptosis. The likelihood is the carotid artery dissection because there is a headache. We have discussed in our module also when the patient comes with headache and neck pain, you should suspect the possibility of a dissection. We have discussed it in our modules when you're discussing about the stroke classification systems and other etiologies of stroke. We have discussed that in a dissection they usually present the neck pain and headache, and those in young patients. So this is a classical presentation of carotid artery dissection. Again, even if you doesn't read understand the entire thing, go to the option. Option is discussing about dissection, stenosis and all those things. So obviously you will understand from the option that the question is dealing about dissection. And vertebral dissection, why should it produce a ptosis and hemiplegia on one side? Vertebral artery can present with ptosis, but it won't produce that much severe dense weakness, and it can produce ptosis if it involvement of hypothalamic or thalamic area. Then you come to the option, you can see that the vertebral artery goes like this. And again, I have explained during my session a different angiogram. I told that to trace external carotid, carotid has an S-shaped curve. So this is the right side carotid. You can see that there is a left side carotid is internal carotid is not seen properly. Left side carotid is not seen properly. You can see that a bulge here. So that is a dissection of the left carotid is the answer, because clinically patient has a headache, ptosis because of the left carotid dissection. The carotid sympathetics are affected, that produce a left-sided ptosis, and left carotid dissection has produced a right-sided weakness. So the answer is a carotid dissection. Even without angiogram you can tell, but with angiogram it is more confirmed that vertebral artery is, you can see separately here, basal artery. We have discussed lot of angiographic images during the discussion. In the stroke we have traced vertebral artery, we have traced carotid artery. I don't think it will be difficult for you with the clinical background and this thing. If you have seen the stroke module, it will be easy to answer this question. The answer is carotid artery dissection. Then coming to fifth question, the patient presents with headache and angiogram showed dissecting aneurysms. I think they had given one more clue as they had shown that there is an SH. There is an SH also was given in the question. I think I'm not sure about that. But anyway, patient has a dissecting aneurysm. That means aneurysm rupture was there. Which among the following is true regarding delayed vasospasm? So delayed vasospasm we have discussed in detail during the discussion of the MCQ of aneurysms and CVT. We have discussed about the delayed vasospasm. The option is it occurs in which among the following is true is the question. It occurs in 1 to 3 days. TCD shows increased velocity with the Lingard ratio of increased velocity of MC also they had commented, I think. I'm not sure about that. Anyway, increased velocity with a Lingard ratio of more than 3. And the same risk in aneurysmal and non-aneurysmal SAH. We have discussed that aneurysmal and non-aneurysmal SAH are different. The management is different. Non-aneurysmal, the causes are different. All those things we will discuss in the module. Once again, I will tell aneurysmal SAH means a cortical SAH, CVT, hemorrhagic transformation, or an RCVS. All those things we have discussed in the module. All these are causes of non-aneurysmal SAH. So we have discussed in the module. This is the same slide in the module. A delayed vasospasm usually occurs in 7 to 10 days, but up to 15 days is a new Bradley. 15 days, up to 15 days you can occur. And most frequently in the MCA. And release of oxyhemoglobin, blood products and free radicals, lipid peroxide oxygen, endothelin, all these causes vasospasm. And here I have specifically discussed about TCD. I had written during the slide about TCD and told that TCD, transcranial Doppler, you place over the MCA velocities are increased. That tells you that MCA vasospasm is there because it is most commonly in MCA. This is a slide which I have discussed in the MCQ discussion on aneurysm. I have specifically mentioned about the importance of transcranial Doppler. I told that transcranial Doppler has been useful one in locating the embolic stroke of uncertain origin with the PFO, and second is in SI. These are two situations I told transcranial Doppler is very much useful. So this was the answer was here. The TCD shows increased velocity in Lingard ratio. Lingard ratio I had not mentioned, but you don't need to understand that to answer this question because I have mentioned that it occurs delayed vasospasm not in the first day, it occurs in 7 to 15 days and it has risk in aneurysmal, not in non-aneurysmal SAH, and TCD shows increased velocity of MCA with a Lingard ratio of more than 3 was the answer, correct answer. So what is Lingard ratio? It is a ratio of flow velocity of MCA and ICA to MCA ratio. The ratio 3 or above, which means that the velocity started increasing, that is a mild vasospasm. 3 to 6 is moderate and more than 6 is severe vasospasm. This is known as a Lingard ratio and vasospasm criteria. No need to understand all those things. Just go understand that vasospasm MCA gets stenosed. So the flow velocity will increase on transcranial Doppler. So that is the answer was correct, which we have discussed in our module. And the next question was patient presented with SH and after 15 days patient has weakness to the right side of the body and they had given that electrolytes were normal, something like that also given. That is not required to answering this, and this was the stem of the question and the possible causes. Hydrocephalus, rebleed, delayed vasoconstriction and thrombosis. Rebleed again present like SAH only, can present with worsening of symptoms, but here I think the best option is delayed vasoconstriction because again it is a right-sided weakness, that means the left side MCA might have undergone vasospasm. I think the best answer is delayed vasoconstriction. Again the same thing we have discussed. So that was the two questions came on SAH and vasospasm. And abrupt onset of abulia, apathy, incontinence and lower limb weakness indicates likely involvement of which area? This also we have discussed multiple times. This is a very common question which comes in the PG as well as UG. Incontinence because of the precuneus, the cuneus, that is the medial area involvement where your bladder control is there. The precuneus area involvement where the bladder control is there. Plus abulia, apathy, we have discussed that the medial, that frontal lobe has a medial frontal, is a medial frontal area, and dorsolateral prefrontal and orbitofrontal. Orbitofrontal is basically your behavioral response. Medial frontal is basically the energization which produce the energization deficit, abulia and all those things. We have discussed it rightly. And dorsolateral is associated with episodic memory loss. Spontaneous infarct will not produce incontinence, will not produce ebullient apathy, but they can produce akinetic rigid syndrome. MCA territory will produce aphasia, not with incontinence, ebullient, lower limb weakness. MCA will produce upper limb and face predominant weakness. So that is also not the answer. Medullary lesions is likely to produce either ataxic weakness or your lateral medullary syndrome or a medial medullary syndrome. Again, that is not the answer. It won't produce abulia or incontinence. So the answer is bilateral ACA, which we have discussed here. A crural, this is the same slide where I am writing the same thing, which I have written is crural monoparesis. Incontinence because of paracentral lobule, you know this is a paracentral. Cingulum and the medial frontal area produce abulia, and apraxia, callosal apraxia can present in ACS stroke. This is what we have discussed in our two studies, where I have written rightly that apathy and abulia are classically present because of medial frontal involvement, because of ACS stroke, and the precutaneous involvement will produce crural monoparesis, apathy, abulia, transcortical aphasia, limb apraxia, incontinence. This was rightly I had discussed the same question. It is usually very commonly asked question, ACA territory stroke. So same question, the answer was actually, I think it is a very easy question among the all questions in the stroke. This requires much analysis like the other question. Other question very practical and difficult one. This was a little bit easier. And then comes the questions on neurosurgery. This was, I feel, very difficult to answer. I felt it was difficult to answer for a MD level. It is very difficult because it is even now the guidelines are not that strict guidelines are not there. So the first question is patient present complaints of seizures, headache, and imaging shows an occipital deep, and they had mentioned, I think, as a large AVM. That I think it was their large AVM. And what is the next step in the management? So patient complaints of headache, seizures, imaging shows occipital deep, large AVM. What is the next step of management? Whether you will go with conservative management, embolization, resection, endovascular clipping. Again, I remember that they are not mentioned about refractory seizures. They had mentioned seizures and headache. So whether you will operate the AVM, that is a question. So what are AVMs? AVM we have discussed a little bit when we are discussing about epilepsy as well as in the bleed. So AVMs are abnormal communication between the veins and the arteries, and this communication between the vein and arteries are actually without capillaries. So there is abnormal high pressure communication between veins and arteries, and there will be a nidus of blood vessel in the middle part. That nidus is known as, nidus is responsible for all the symptoms. There is a risk of bleed, all those things are there. You can divide the AVMs into symptomatic and asymptomatic. Symptomatic, they present classically with hemorrhages, seizure, headache or focal neurologic deficit. These are the four presentations of symptomatic. And most common hemorrhage is intraparenchymal hemorrhage. And extraparenchymal, that is subarachnoid hemorrhage and IVH, intraventricular hemorrhage, are 1/4 of cases can present, but majority are present intraparenchymal hemorrhage. And AVMs with hemorrhage has a better prognosis compared to other etiology, even though the mortality and morbidity are high. But compared to SAH or other etiologies, AVM with hemorrhage has a better prognosis. Those are asymptomatic. Around 20% AVMs are detected during incidental imaging. You will find out an AVM. And risk of bleed for an asymptomatic is around 1 to 3% per year. Okay. So this is the classification of AVM, symptomatic and asymptomatic. Clinically, you can classify. Asymptomatic, around 1 to 3% risk of bleed is there. So the question is here again, it is unruptured AVM, not ruptured AVM, unruptured AVM. What to do? That is the question. So treatment options remaining are, the main aim is to prevent hemorrhage, not prevent seizure, not prevent focal deficit. The main aim of treatment of AVM is to prevent a hemorrhage. You have three options. One is a microsurgery, second is a stereotactic radiosurgery, and third option is an endovascular embolization. Ideal treatment is again combination of therapy. Again, the option, there is no combination therapy. Again, that will create confusion, but answer is simple. I'll come to that later. So basically, AVMs are abnormal communication between veins and arteries, and they can be either symptomatic or asymptomatic. Asymptomatic are 10 to 20% incidental finding and 1 to 3% risk of bleed. And treatment options are microsurgery, stereotactic radiosurgery, endovascular embolization. Ideal is combination therapy. So about AVMs, AVMs has four symptoms. Those are hemorrhage, seizure, then focal neurologic deficit and headache. And classical four symptoms, three treatment options, and they have two types, either symptomatic or asymptomatic. Okay. Or you can also divide into unruptured and ruptured. AVMs are abnormal communication between veins and arteries. They have a nidus in between. That nidus is what you can see here. These are the nidus of vessels. These are nidus of vessels which, these vessels are the nidus of vessels. These are nidus of vessels which are, whenever you treat an AVM, you should supposed to obliterate all the communication, all the feeding vessels, needles should be completely removed. Otherwise, it will become symptomatic. Again, the risk of bleed is around 1 to 3% for asymptomatic. Okay, so these are three major things. Four types of symptoms, 3 types of surgeries, and 1 to 3% risk, and around 2%, 2 types of classifications. One is symptomatic and asymptomatic. Second is ruptured and unruptured. This is a recommendation of a consensus guideline. Nothing. You don't need to study everything. Just remember that any form of treatment given for AVMs should have complete obliteration of the nidus. If the nidus is patent, the symptom will come back again. Risk of bleed will again come back. So any treatment, nidus should be completely, all the vessels and nidus should be completely removed or obliterated. So microsurgery, you do a craniotomy and then you find out the feeding vessel, you cut off all the feeding vessel, then remove the nidus completely and then close it. This microsurgery carries a risk for bleed and all those things. The post-surgical damage, post-surgical deficit can occur. So they divide in grade based upon a system known as Spitzler-Martin grading system. Spitzler-Martin grading system. Based on this is a Spitzler-Martin grading system where they grade the AVMs based on the size less than 2, 3 to 3, less than 3, 3 to 6, more than 6. And venous drainage is superficial or deep. Anything which is superficial cortical AVMs are known as superficial. Anything where it is deep to the cortex, they are supposed to have a deep venous system. Here in our question, the patient had a deep occipital. That means it is a deep type. So, and eloquent cortex or non-eloquent cortex. All those things are classified based on this scoring. They classify into grade 1, 2, 3, and 4 and 5. There are 5 grades. Based on this, no need to understand the depth of that. Just go and understand that those with superficial are grade 1 or 2. They have a post-surgical 2% risk of post-surgical complication or deficit. But those with grade 3, they have 17%. 4 or 5 have 45% risk of post-surgical complication when you are going with a microsurgery in a surgical methodology. So because of that, only grade 1 AVMs, microsurgery is best. You can do it very easily, very superficial, small AVMs. Grade 2 also microsurgery you can do. But grade 3 and 4, 3 is again ambiguous. 4 and 5, it is very adjacent to the eloquent cortex. It is risky to do surgery. So microsurgery is best for grade 1. And grade 2 also you can do. Grade 3 is tricky. Grade 4 and 5, it is the better in individual treatment. Microsurgery is not easy. You have to go with a combined treatment. Then stereotactic radiosurgery, it is where you will give a stereotactic localization of the lesion and then you give a radiation. So, therefore, risky lesion where surgery is due to anatomic or the extent risky for surgery, or they are because of medical reason the patient cannot undergo surgery. That's conditions you can go with stereotactic radiotherapy. But the problem is stereotactic radiosurgery is a latent period. So, after the radiotherapy, it takes 2 to 4 years for the lesion to obliterate completely. So, that is known as a latent period. During the latent period, they can have a bleed, and the risk of bleed during the latent period is almost similar, around 3%. So because of that, the stereotactic radiosurgery up to 4 years, they can have similar bleeding risk as a non-treated one. So when you treat isolated only with radiotherapy, so again there is a need of combined therapy. Microsurgery, grade 1 easy to do, grade 2 okay, grade 3 it's confusing, grade 4 and 5 difficult to do. You need a combined therapy. The combination usually done with embolization. Embolization can be done as a pre-operative procedure. For those who are large and deeper before microsurgery or stereotactic radiosurgery, you can do an embolization, obliteration of the nidus and the connecting vessels can be obliterated. That is the first way. Second way is a palliative treatment. Those with large AVM and deeper, unable to resect, and vascular steal phenomena or venous hypertension, they are stealing the blood from the arteries, or they are stealing flowing blood into the venous system, producing a venous hypertension, presenting headache and increased intracranial pressure. Such condition you are unable to resect it, but you can do an embolization to reduce the feeding vessels and reduce the draining vessels so that the venous hypertension improves or the vascular steal phenomena improves. That is known as palliative treatment. And third, as a definitive isolated treatment of embolization is not used that much, but that also is a possibility. And risk of intracranial hemorrhage and stroke is high for embolization when you are doing embolization. So that is a problem of embolization. So you have 3 treatment options: microsurgery, stereotactic radiotherapy, and embolization. Grade 1 you can go with microsurgery, but individual treatment is not advised. Advised is a combination treatment, especially for large one. You do an embolization followed by either a stereotactic radiosurgery or a microsurgery. Stereotactic radiosurgeries were done for those which are difficult to resect, and those who are deep and occipital can go with a stereotactic surgery. Again, a latent period of 2 to 4 years. Based on Spitzler-Martin's grading system. There is one more grading system is there. That is known as Lawson-Young grading system. That is what is given here. This is a Lawson-Young grading system. This is supplementary. Add on with SMG, you will call it as Lawson-Young grading system. No need to understand that. So just understand that this was a AV malformation. It can be symptomatic, asymptomatic, 4 symptoms, 3 treatment, and 2 types are there. Just come back to the classification. You can unruptured AVM and ruptured AVM. What we were discussing in our case was a patient with headache and seizures, and there was no history of bleed. So there is an unruptured AVM. Unruptured AVM, whether you should treat or not. There is a trial which is done, which is known as Aruba trial. Based on that, a randomized trial on unruptured brain AVM trial or Aruba trial. Based on that, what is the recommendation right now is go for conservative management in unruptured and may be treated with epilepsy and focal neurodeficit which are not improving. Then you can go with surgery. Otherwise, conservative is the best approach. And repeat MRI after 5 years, and anti-epileptic drug and headache management is a core management of unruptured AVM. And if with anti-epileptic it is uncontrolled seizures or refractory seizures, then go for surgery. So, coming back to our question, here's a patient with headache and seizures. Imaging shows a deep AVM, and what is actually the best option will be a conservative management based on Aruba trial. Because those treated with surgical has more complication compared to medically managed group. Because of that, those with headache and seizures unruptured, you can go with conservative management, monitor with every 5 years with MRI, and treat seizure with AED, treat headache like a vascular headache, and if it is refractory, severe symptoms, then you can go with surgery. Otherwise, conservative management is the first line. So the answer is conservative management. No need to go for embolization, resection, or endovascular clipping is never done for this. It is done for aneurysms. So that was about the unruptured. For ruptured, what will you do? Once the rupture happens, the risk of bleed is 4 to 5 fold. Then you have to do surgery. For ruptured aneurysms, when it is superficial and grade 1 Spitzler-Martin, superficial, you do a craniotomy, evacuate a hematoma. During the hematoma evacuation, you can do an AVM resection. But if it is deep or larger one, better to avoid surgery in that setting because there will be brain edema. Once the brain edema settles down, that is around 2 to 3 weeks later, you can resect it. Either microsurgical or a combined method or a stereotactic radiosurgery. And best method is a combined by using embolization with a stereotactic or a resection. So that is for ruptured AVM. So there is a treatment for unruptured AVM and ruptured AVM. The question first asked was unruptured AVM. So recommendation is those 3 and 5 multimodal approach, and grade 5 AVMs are treated conservatively. So basically, those with AVM, you can divide it into ruptured and unruptured. Those with a ruptured do surgery, ideally a combined method. If it is superficial, immediate surgery. If it is a deep one, you go with initial craniotomy and evacuation, then 2 to 3 weeks later you can do a surgery. And if it is unruptured, then what will you do? Unruptured, it is conservative management is the best thing. So our first question was conservative management because it is an unruptured AVM based on Aruba trial. Now next question is ICU bleed patient present intracranial bleed and MR angiogram shown below. It is the next step of management. Actually, when I saw the MRI was not at all clear. You cannot zoom it properly. And I could not get an exact image of that. I feel that might have been better if you are able to zoom it properly. But what I could find out that there was an ACA level, there is a AVM, supposed to be AVM. I feel like it was an AVM because image was not at all clear. So again, it is a bleeding with AVM, it is a ruptured AVM. So we are just now discussed ruptured AVM, you have to resect it. So ruptured AVM, your treatment is endovascular therapy, clipping, conservative management, embolization. So 3 options given. But ideally the treatment is embolization with resection. But when you compare, so conservative management is option for unruptured. So that is not the answer. Endovascular therapy and clipping is never done for AVM, it is done for aneurysms. Either resection or embolization. These were the 2 options, it was confusing. I felt the examiner might have meant this resection because ultimate treatment is resection. Embolization alone cannot be a treatment because I told that embolization, there is a, see here, embolization there is a risk of ICH and stroke, intracranial hemorrhage and stroke is there. Because of that, you cannot do an embolization at that time. So better option is a resection, but resection is better to done after 2 to 3 weeks. At that time, you can reassess with an angiogram and you may have to go with a combined approach with a small embolization of the feeding vessel, then you do a resection. Depends upon the surgical thing. But again, this is a pure surgical question. But I feel the best answer is answer A, resection. Just the image was given somewhat like this. It was an ACA A2 level neurism. It was not the exactly angiogram. It is an MR angiogram image also. I could not get an exact image, but there was a structure somewhere like this. I felt it was an AVM because it was not that clear. And one more clue was it was IC bleed. If it was an aneurysm, they might have given us a SAGE. So I think it was an AVM, and the best option is a resection. So that was that question. It was confusing thing. A female complaining of this is again an interesting question. It is actually very high funda level. It is a DM level question. And the female complaining of episodes of pulsatile tinnitus, and they are also tell that giddiness. I forgot to mention that giddiness and pulsatile tinnitus. And while lifting heavy weight, complaints of visual blurring and fall. This was the structure was somewhat like that. An examination showed papilledema. And she had a past history of CVT during pregnancy. I think she saw an anticoagulation also, that was mentioned. Now NCCT brain is normal. Non-contrast brain is normal. What is the probable cause? So here again what I told is the catch point. The catch point here is a pulsatile tinnitus and giddiness. So this pulsatile tinnitus, giddiness and presence of papilledema and CVT. These are the 4 catchwords, because I have mentioned when we were discussing of spinal avidural fistula, there can be, I had mentioned that tinnitus can present in, I think I have mentioned tinnitus, as well as I have mentioned that you can auscultate and see the bruit. So this bruit and the pulsatile tinnitus are classical feature of dural AV fistula. And dural AV fistula image, plain CT may be normal, and they will have hypertension because of AV fistula. The arterial blood is glowing to the venous blood, that will produce venous hypertension and raised ICP and papilledema. So papilledema and presence of CVT in the past and all those things favor, the best option I feel is a dural AV fistula, because AVM with this presentation of raised ICP and all and presence of CVT, all those things doesn't goes together with AVM. AVM, the complications are bleed, seizure, focal neurodeficit, all those things. CVT is not a complication, but dural fistula they can present with this one. Dissection is not the answer, aneurysm is not the answer. So I think the best option is AV dural fistula. Again, it is a very tough question and very high funda level question, high DM level question. Pulsatile tinnitus was a catchword, and the papilledema. I think these two were the catchwords in this question. The answer was box, AV dural fistula. So next question was actually again a neurosurgery question, and actually the question was looking lengthy and lot of clinical things were given, but those things are not required. You can answer it with routine logic. A 3-year-old child with SDH with midline shift, without midline shift, and image was given. The image was actually not required at all. And GCS score of 5 and ICP of 25 to 29, a mean arterial pressure of 20, and a midpoint, pupil is midpoint and sluggishly reacting on some barbiturate, some injection they had given, I am not sure about that, and ventilated. What is the next step in the management? So first option was repeat CT after 12 hours and then decide. The next option was repeat CT not required, take for emergency craniotomy, something like that, and some dose about phenobarbital, something was given in the option, and next option was conservative. So here actually it is very simple. That you can see that GCS score is very poor. 5 means patient is almost like comatose, and the ICP is very much raised. Intracranial pressure is very much raised, even after on ventilation and barbiturate or some sedation was given. I'm not sure what was barbiturate or sedation, something like that was it. And the mean arterial pressure is low. So the patient already has been given ventilator, already has been given support. Still the GCS is poor and raised ICP, features of raised ICP is there, and there's a midpoint sluggishly reacting pupil. You could not wait for that. You should go for craniotomy. That much logic is enough to answer this question. So the answer was repeat CT is not required. Go for emergency craniotomy or some drainage was there. That was answer. Surgery for SDH. If the thickness of SDH is more than 10 mm or a midline shift of more than 5 mm, regardless of the GCS, take for surgery. Okay. So instead of any patient with a 10 mm more than thickness of SDH or a more than 5 mm of thickness, midline shift, go for surgery. And those with thickness less than 10 mm and MLS less than, midline shift less than 5 mm, GCS less than 9, then you should do an ICP monitoring. And they had done ICP monitoring, GCS is 5 and they did an ICP monitoring. And those with GCS less than 9 and thickness of less than 10 and MLS less than 5, surgery is indicated if a drop in GCS score 2 or more during the admission. That is not mentioned because GCS is mentioned as 5, Whether there was a drop in that question, it is not discussed. The next thing was asymmetric or fixed pupil. Here the patient was having a mid-position pupil, sluggishly reacting, and ICP 20. ICP was raised 25. So you have to know other option you take for surgery. Actually, without knowing all those things, with the common sense, you can answer the question as take for emergency craniotomy. I think doesn't need much details of that. A 70-year-old with acute hemiplegic stroke on day 2, imaging done, which is shown below, and patient is in E1 VT-M3. This is what was given as the GCS score. Again, a poor GCS score of around 3 to 4, that means almost comatose, and asymmetric pupil. That was the catch point here. At day 2, what is the next step in the management? There is not much confusion. I am not sure on fourth option. I think again this is little bit ambiguous question if you go theoretically. But what the image given was there was some midline shift, some compression of ventricle, but it is less than 5 only. A small midline shift was there, and there is a dense MCA infarct, or which is a malignant MCA infarct, which we have discussed in our module surgery in stroke. If it less than 60 years with worsening, in 48 hours surgery to be done is surgery 2A evidence. In more than 60 years it is 2B, but even though it is 2B, here it is given that asymmetric people. And you can see the image also. It is almost similar image was given. So I think the best option is an emergency craniotomy. Again, I feel all these questions there will be a lot of confusion will be there whether to go for a conservative emergency if you go into the theory in detail. But practically, whenever there is a stroke patient, you are supposed to do a craniotomy if it's a malignant MCA and before a fixed pupillary deficit has been developed. Because if there is a worsening of score, you should go with surgery. And even if there is a midline shift and dense MCA, you are expected to get worsened edema. The edema will be maximum in the 3 to 10 days. In 3rd day or 5th day, the maximum edema. So day 2. Next day, the edema will going to increase. You are already given medical therapy for 2 days. Now there is no need of waiting. You have to go with surgery. So the answer is emergency craniotomy, which we have discussed in the stroke module. So stroke and vascular, there are total 12 questions. There are 4 new questions. 2 questions on AVM. I feel both the AVM questions were tough and difficult one. SDH, even though the question looks very much difficult, but it is easy to answer. AV dual fistula was also a tough question. These are the 4 questions which came out of the box. Remaining all the 8 questions where we were discussing in the modules only. But I feel there are very few tough questions also came in that module. So that finishes the stroke area. And the stroke area, I feel the most tougher questions were came on the stroke areas because most were clinical and practical questions. Now come to peripheral nerve, NMJ and muscle and genetic questions. There are total 14 questions were asked. Go to the first question. Actually, first question was the questions were not that tough in this area. First question was they had shown an image of scapular winging, almost similar picture, because I personally have seen the image. Which among the following nerve is not involved in the below condition was the question. Actually, it is a little bit simple. Suprascapular nerve, long thoracic nerve, dorsoscapular, spinal accessory. So this was same thing we have discussed in our module on other dystrophies in muscle disease, where I had drawn the scapula and written that when the scapula stands like a structure like this is a medial surface, is a lateral surface, the upper surface, and you will have different muscles pulling on the scapula. One muscle is upward pulling is trapezius. Here serratus pulls here and rhomboids pulls here. These 3 muscle weakness will produce scapular imbalance and winging. That is what I had shown here in this picture and during the module. So weakness of any of these muscles. So trapezius supplied by spinal accessory. So that will produce scapular winging. Then dorsoscapular supplied rhomboids again can produce. Long thoracic which supplies serratus center again can produce. The answer is suprascapular nerve which supplies a supraspinatus, infraspinatus, doesn't have nothing to do with the scapular winging. So that is the answer. Answer is A. It is actually a simple question we have discussed when the beginning of the module where we are discussing the initial case discussion on the FSHD. I had shown one case on scapular winging and I had explained about how the scapular winging, all those things happen. So the first question. Second question is GBS, severe autonomic dysfunction. Which among the following is better avoided? Actually, it's the same thing which I told during the module on GBS, the treatment of GBS. IVIG, plasma exchange, CSF study, left lateral position. Which among the following you will not do? So, in the management of this thing, I had told that these are a treatment option available. IVIG or PLEX can be given. IVIG or PLEX, any of this can be given. But I had told specifically that only condition where IVIG is chosen is one. PLEX is better when you are giving more than 3 weeks. There is no guidelines, still both are equal. But in the newer journals, especially in the Continuum Journal of AAN, American Society of Neurology, they had mentioned in the 2020 peripheral nerve edition, they had mentioned that if it is more than 3 weeks from the onset, plasma exchange might have some merge. That is only one difference. Second is, I specifically told when the patient is in autonomic failure, in the hypotension, you cannot take for a plasma exchange, because when you draw the blood into dialysis machine or the plasma exchange machine, there is a risk of BP drop. That I have specifically told during the session on GPS during the management. The answer is plasma exchange is again simple and again directly from the module. And the case of tuberculosis on ATD, again this question was a bit different, like patient was started on intensive phase, all those things. There was no need of, I think they were trying to make you read a lot and making confuse you a lot. The case of tuberculosis on ATD and complaints of painful neuropathy, which among the vitamin B deficiency will causes. And patient was again mentioned that patient was on INH. The question they had mentioned on INH. So INH known to affect pyridoxine, because INH the structure is similar to pyridoxine and vitamin B6 or pyridoxine, and that will produce pyridoxine deficiency. That is why you will give pyridoxine tablet during when you are giving ATD, or tabpenadol or pyridoxine you will give. The answer is simple, vitamin B12. Actually, we have discussed in our peripheral neuropathy module that these are pure sensory neuropathies. We have discussed pyridoxine toxicity, and the question was again practical. When you do treating ATD, you might have seen in the wards you are giving pyridoxine, the benadryl tablets you used to give along with antitubercular drug therapy. So it was again a very practical and it was not a difficult question. The answer is pyridoxine, vitamin B6. And the child who was on ventilator, this was again a very tricky question, and I actually exactly doesn't remember the exact structure of the question, and there are some points I need to confirm. You can put in the comment box, or you can mail to Marrow whether what was exact question, because child who was on ventilator and was given some scenario and given that patient is on ARDS on ventilator and then develop a flaccid quadriparous and areflexia. I am not sure whether it was written that patient was weaned off, because that is very important. And NCS shows distal latency of 4.4, amplitude, and they are given a box with distal latency. Latency was around 4.4 of median nerve, and amplitude was given as 0.1. That is what I remember. Amplitude is very low, and CPK was 54. EMG shows large amplitude, there are some discharges with reduced recruitment. This was a catchword here, and again CPK. So, what do you think? The options AADP is never the answer, because they are showing amplitude is very much reduced and distal latency is slightly prolonged. But when you see into my module on peripheral nerve part 2, on approach to peripheral nerve part 2, where we discussed NCS as well as in the GBS, I have mentioned that when the CMAP or the complex motor potential is very less than 2, you cannot comment on distal latency because the wave will be very small. So you can see that it is an axonal pattern. From the NCS, it is an axonal pattern. But again, the axonal patterns only motor, you can still think of a critical illness myopathy or critical illness myoneuropathy. Here the CPK is normal, but again in critical illness myopathy you can get a normal CPK. That also we have told in the muscle discussion. Critical illness myopathy you can get a normal CPK also. So critical illness, so again the catchword is this one, reduce recruitment. When you can go to the module and see in MND, motor neuron disorder, where we are discussing about the investigation, I have told specifically in detail about EMG, where I have told that during the EMG, the neuropathy and myopathy can be differentiated by the recruitment. Recruitment is reduced in neuropathic disorders, while myopathy recruitment is early. That I have specifically mentioned. So this tells you that it is a neuropathy, not myopathy. So critical illness myopathy is out. I will tell about recruitment once again. So during a EMG examination, you will first put the needle into the muscle and see any spontaneous discharge. That's the first thing. Second, you will see the MUAPs, motor unit action potential. Ask the patient to contract the muscle and measure the MUAPs. Then you will see a recruitment and maximum volitional activity. Maximum activity, you will give maximum power and see the response in the EMG. In between, you will see the recruitment. Recruitment means you will tell the patient to slightly start moving the limb. So you have multiple muscle fibers are located like this. Many muscle fibers are there, and you are starting to move the limbs. When the initial motor unit, first motor unit is recruited, producing an MUAP, and the muscle started moving. When you need to give extra muscle strength, you need to give more power. In order to give more power, either you should give the maximum power from the muscle, or you should recruit the next muscle, next motor unit. one motor unit start contracting, giving the power that is not enough to give the start the movement, then it has to recruit the next muscle. That is known as recruitment. So recruitment is done by the nerve. There is a nerve divides into different motor. The nerve gives, this is a one motor unit. This is another motor unit supplied by nerve number 1, supplied by nerve number 2, supplied by nerve number 3. First, the first motor unit start contracting. Then the CNS has to recruit the next motor unit. Then the next motor unit will come and act. So when this is known as recruitment. So I am not going into details. So if there is a damage of the nerve, that will produce decrease in recruitment. It cannot be recruited at a proper time. So that is known as decrease in recruitment. So that is known as reduced recruitment. That means neuropathic damage. In muscle disease, what happens is, before the time when normally second motor unit is going to act, as the individual motor unit, this motor unit has a muscle disease. So that is weak. So it has to recruit the next unit early to produce a movement because the motor unit is weak. That is known as early recruitment. Understood? Here the problem is with the motor unit, not with the nerve. So then the muscle cannot give enough power. So increase power, either it should recruit the next unit or give the maximum power. It cannot produce maximum power because muscle is damaged. So it will recruit the next unit early. So that is known as early recruitment. So early recruitment is a feature of muscle disease, and late recruitment, reduced recruitment is a feature of neural disease. This I have mentioned in my module on motor neuron disease on the ALS session, on the investigation of ALS, where we are discussing about the Awaji-Shimagi criteria and all those things. I have mentioned specifically how to differentiate muscle, neuron disease, all those things in EMG. So that is, with that was one clue, so that is a neuropathy. So the remaining option will be, one is a acute motor axonal neuropathy or AMAN, or a critical illness polyneuropathy. So again, that is where the question whether a weaning off is important for me. Because if weaning off was done, patient is not on ventilator, the possibility of AMAN also should be considered. But if the patient is not weaned off, still on ventilator dependent, then it is critical illness polyneuropathy. That is what I think is. I am not sure about the question. Because the criteria for IC associated weakness includes a weakness developing in the onset of critical illness, after the onset of critical illness, that is there after ARDS, cellular weakness. Weakness is generalized, symmetrical flaccid, usually sparing the cranial nerves. That also is given, sparing the cranial nerves. Only quadriplegia they are mentioned. Because AMAN and all those things usually affect facial nerve also. And around 50% will have facial nerve. And causes of weakness are not related to any other critical illness should be excluded. Muscle power assessed by MRC should be, some score should be less than 48. And dependent on mechanical ventilation. The patient is not dependent on mechanical ventilation here. So I think there is an option either of this, but I think because they are not given the power exactly, and if patient was not weaned off the ventilator, there is no confusion, it is critical illness polyneuropathy. But if the patient is weaned off this one, I still think the possibility is more likely to be a critical illness polyneuropathy. I am not sure of the entire question structure. So I think the answer is critical illness polyneuropathy. So this is a criteria just given in a journal. This is critical illness polyneuropathy and critical illness myopathy. We're not going to see the myopathy. We are going to see the neuropathy because there is a reduced recruitment which favors a neuropathic process, and CP was normal. So critically ill patient, that is there. Then limb weakness is present, that is there. Third thing is difficulty in weaning from mechanical ventilator support with exclusion of cardiopulmonary causes. That is mentioned or not, I am not sure. Third point which is given in the criteria is difficulty to wean off from a mechanical ventilator. And the fourth point is electrophysiological evidence of axonal sensory motor. They are not given out sensory, they are given only motor. And other causes of neuropathy should be excluded. Example, porphyria, acute massive intoxication of heavy metals, and vasculitis. So with this criteria, what I am thinking is, if the weaning was difficult, then it is more likely to be critical illness polyneuropathy. If weaning was able, then it may be an AMAN also is a possibility. But still, I think as they are not mentioned about the facial, what they meant was critical illness polyneuropathy. I also feel that this is little bit ambiguous question and very difficult question. For an MD level, it is very, very difficult because it's a DM level question. Then coming to next option, which among the following causes painful neuropathy? All of the following causes painful neuropathy except which among the following is not a painful neuropathy? So the options are amyloidosis, diabetes, leprosy, and vasculitis. This is what we have discussed in our module on approach to neuropathy, where we discussed about a patterned approach. And the end of patterned approach, I discussed that a small fiber neuropathy or painful neuropathy, HIV, vasculitis, cangias, diabetes mellitus, amyloidosis, HSA, and Fabry's disease, which produce pain predominant. Again, Fabry's, one more question was there, lancinating pain, that is from this module only. But I will come to that question later. So, HIV, vasculitis, diabetes, cangias, amyloidosis, HSA. So in the option you see amyloidosis is there, diabetes is there, vasculitis is there. Leprosy is something which doesn't present painful neuropathy, rather they present predominantly motor neuropathies. And pain loss is a feature. Sensation loss is a feature. So the answer is leprosy, again directly from the module, NEC question. And the next question was again very much tricky, and as I feel again it's a bit DM level question, but it is with common sense you can answer it. CKD patient on hemodialysis, complaints of sensory symptoms during night over the left palm, I think they are given, or hand. On examination, there was no deficits, no sensory or motor deficit. NCS, they are given a graph of MCS, exactly not this, something like that. They are given a left and right risk graph. And which among the following is true? Surgery is not required at present due to deposition of amyloid. This condition is due to deposition of beta 2 microglobin and due to recurrent hypoglycemia. Anyway, the symptom is not because of recurrent hypoglycemia. The confusion was between these three options. And when I saw the NCS, actually it is very tough because they are given the NCS, you have to analyze the NCS. NCS, the distal latency was prolonged in the wrist. I could not get an exact image, but the CMAP was normal. It is more than 5. CMAP, the complex motor amplitude, was more than 5. That was enough to tell the answer. Because in this, the diagnosis was CTS from the NCS. Because the wrist to palm segment, there was an increased distal latency. And the symptom was also corresponding to CTS. Even with the symptoms, you can directly tell it is CTS. Carpal tunnel syndrome is what they meant in the option. And for the carpal tunnel syndrome, the surgery is indicated either if there is a wasting is there or a weakness is there, or the third option is when there is a CMAP, complex motor amplitude, is less than 5. Here the complex motor amplitude is more than 5 and only sensory symptoms and no deficit on examination. So there is no need of surgery at present. That is the best option. And again, when you take a common sense, these two options cannot be correct together. First thing. Second thing is amyloid with CTS. I have discussed about amyloid with CTS when you're discussing about peripheral nerve. And amyloid and CTS, they present hereditary amyloidosis, not in acquired amyloidosis, hereditary amyloidosis. And beta 2 microglobulin has nothing to do with the carpal tunnel because of carpal tunnel. Thickening of the carpal tunnel is one reason. And among the option, I feel the best option is surgery is not required at present because CMAP is higher and there is no deficit. That is again is a more clinical question. There is no deficit. Clinically, CTS without deficit, better to go with medical management initially. That is a basic clinical thing. You don't need actually NCS to tell the answer because again it is a very pure clinical question. But it was a bit tough when you see the question with the reading the NCS and all, you will get tensed. But if you just take it in the common sense, symptomatically it is CTS and there is no deficit. And first time, they are presenting for the first time, you can go with medical therapy. Surgery is not required. That is actually, if you think in the common sense, that is very easy. But in the exam hall, it is very difficult. You will not think like that and all in the exam. Whenever you see such a complicated NCS and all, you will get confused. The patient complains of recurrent dysphagia, dysarthria, nasal regurgitation. What is investigation? It is very simple question. And recurrent dysphagia, and that means episodic dysphagia, dysarthria, nasal regurgitation. I had told in the myasthenia module. These are symptoms and quite common when you comes with this. The possibilities of myasthenia. Upper GI endoscopy has nothing to do. Perium has nothing to do. Manometry has nothing to do. ACH receptor antibody is the investigation of choice. Clear? So that is the C. And the patient complaint. This was another question. There was something else was there. Like I remember, like some infection was there initially, followed by patient complaints of weakness, fatigue, ptosis, and both the abduction restriction was there. So again, I have told in the myasthenia module specifically that whenever there is a pupillary sparing, ophthalmoplegia and ptosis, always keep myasthenia as a possibility. So the option was, one more option was that I am not remembering it. So it is a weakness following an infection. That means it is a myasthenic crisis. There is a weakness, fatigue is there, and bilateral ptosis, and both the abduction is restricted. Okay. So bilateral ptosis means, and pupil they are not mentioned. So after an infection, this presentation of bilateral likely to be myasthenia only with weakness and all. It is very simple, and the option doesn't have any granular mentioned also. GBS, myasthenia gravis, and LEMS. LEMS present doesn't with LEMS do not present with this type presentation. LEMS present with limb weakness. We have discussed about Lambert-Eaton myasthenia syndrome. Also, we have discussed in the module. Doesn't present like this. So this is a classical present of myasthenia gravis. Again, a simple question if you take the common sense. So most of the questions you just need common sense. Don't get confused. They were trying to confuse you people with the images and further details of history. But there were catch points in the clinical which were easy to diagnose the questions. Which of the following is wrong regarding the patient with Willow sign? They are given this sign below. This actually we have discussed in our module on DMD, Duchenne muscular dystrophy. I had drawn the same figure and told this is a Grover's sign. This is because the proximal muscle weakness, they will try to tripod position and climb up on the knee and up. I have discussed about the type of LMN and UMN gait, getting up difference also. So this is nothing but DMD, Duchenne muscle dystrophy, associated raised CPK. I have told in the module multiple times, whenever there is membrane damage, there will be increased CPK. So this is true. Which among the following is wrong? They are asked. This is true. That is not the answer. Early loss of reflexes associated calf hypertrophy associated with proximal muscle weakness. Calf hypertrophy is common. So this sign itself means proximal weakness. Doesn't need to analyze much. The answer is directly this one. One more thing I will tell you. In DMD, there can be late loss of reflexes. But angle reflex will be retained till the late. But in the early phase, in all muscle disease, in early phase, muscle reflex will be completely preserved. That also I had mentioned in the approach to muscle disease also, and multiple times I have mentioned during the module. Whenever there is a muscle disease in the early phase, the reflex will not be lost. But the late end stage muscle disease, they can have a reflex loss. But still, in DMD, angle reflex will be retained. So don't need to understand all those things. It is very simple. You know that it's a proximal muscle weakness. This is wrong. And you know it is a Grover's sign of DMD, so this is true. This is true. That is you are sure. Calf hypertrophy is a feature of DMD. That also is true. So the only answer remaining will be this one. That is actually very easy. Even though it looks confusing, it is very easy. So we have discussed about different sign. Calf hypertrophy we have mentioned here, and the age, each age, what all signs will be seen. All those things we have mentioned in our modules. The next question was also was looking tricky, but it was very easy. Which among the following is true regarding the below condition? Condition they had given as a tongue figure was there. There is a percussion myotonia was given. So it is a myotonic disorder. Again, it is very clear, tongue myotonia and percussion myotonia. So myotonic disorder, we have discussed 2 modules on non-dystrophic and dystrophic myotonia in muscle disease. A proximal muscle weakness is never seen, first thing. Anticipation can occur. It's a muscle disorder, but in myotonia, they can have a proximal myotonic dystrophy. They can have a proximal muscle weakness in type 1 type of myotonic dystrophy. Anticipation can occur. Repeated movement worsens the weakness. Ptosis is common than cataract. Actually, myotonia, ptosis is less common than cataract. Cataract is the most common thing. So that is wrong. Proximal weakness can present. That is also wrong. Repeated movement worsens the weakness. Actually, repeated movements improves the weakness. Repeated movements worsen weakness is a feature of paramyotonia. That also we have discussed in the module. So this is also wrong. Anticipation can occur is true because myotonic dystrophy type 1 is a triplet repeat disorder. I have mentioned during the slide anticipation, very correct, told anticipation is common in MD1 because of a triplet repeat disorder, autosomal dominant CTG repeat disorder and chromosome number 9. So depending upon the repeat, the severity and onset will be also early. So anticipation is common. So anticipation can occur is a true. Then about the different manifestation also we have mentioned, and we have mentioned in the module that proximal muscle weakness can occur in myotonic dystrophy type 2. Okay, that is known as proximal myotonic dystrophy. So proximal weakness never occur is also wrong. So anticipation can occur, I think, is the better option. But again, there are some confusion if you go into the detail in a neurologist point of view. I'm not going into that. But answer among the option given below, I think the best option will be anticipation can occur. So that was about the paramyotonia. We have discussed that worsens on exercise and cold is something which is paradoxical for paramyotonia, while myotonia improves on the repeated movement. Progressive visual loss, hearing loss, and below finding in a child suggestive of. I think they are mentioned as optic atrophy and ichthyosis also, but the image was given here is there is an ichthyosis. Ichthyosis was given. There is a optic atrophy. Actually, exactly not this one. They are given the fundus also with optic atrophy and retinitis pigmentosa plus optic atrophy. And the catch point was this image. That is a shortened fourth metatarsus. That is, these are classically ichthyosis with a peripheral neuropathy. The first thing will comes to your mind will be rough sums. So actually, it is very simple. It is rough sums, retinitis pigmentosa, ichthyosis, peripheral neuropathy, and a shortened fourth toe. That is rough sums. This is exactly what we have not discussed in the module. This was not we have not discussed rough sums in details in the module, but we have discussed in the clinical approach, the clinical sign. We have discussed that ichthyosis can present in rough sum, and we have discussed that retinitis pigmentosa can present in rough sums. So visual loss, hearing loss also can occur. We have mentioned. So visual loss, hearing loss, and the child with the below findings is suggestive of rough sums. So that was actually it was a good question. The answer is rough sums. Which among the following is an axonal site type of CMD? It is very easy question and direct question. We have discussed the CMD 1, 2, 3, 4 is there. Only axonal is CMD 2. There is the option only CMD 2 was this one. The answer is CMD 2A. And we have mentioned in our discussion in the module CMD classification. CMD 1, 2, 3 and 4, only 2 is axonal. DSS is 3 and 4 is autosomal recessive. All others 1, 2 and 3 are autosomal dominant. We classify into axonal. Again, we are told that axonal is 2. So that is answer is easy. CMD. We have discussed in detail about CMD in the peripheral neuropathy module in hereditary neuropathies. Then cause facies without mental retardation, cardiac regurgitation murmur, joint stiffness, hepatomegaly and no corneal opacity is associated with. This is something which we have not discussed. Cause facies without mental retardation, and the catch word is cause facies first thing. Then there is hepatomegaly, that means a storage disorder, more likely to be an MPS. In the option there are 3 MPS and one was metachromatic leukodystrophy, MPS or mucopolysaccharidosis, and one option was MLD. This is not the answer, that is we are sure this is not the answer. Remaining were 3 options: Hunter, Hurler and Sanfilippo. Hunter, as Rebecca madam has told right in her classes, I still remember her classes in biochemistry during when I was doing my coaching in Thrissur. Hunter needs to hunt. So he cannot have a corneal opacity. So the answer is corneal opacity was not there. The answer is Hunter. So this is actually the same Marrow notes of madam which I have taken from Rebecca madams. MPH1 or Hurler, the enzyme deficiency is again a possible question. Mental deficiency is absent in Hurler Hunter, and this was the thing about enzyme deficiency. So Hunter will not have corneal opacity, and dystosis or the skeletal abnormalities can present all of those. So skeletal abnormality, horse facies, mental retardation which is not there, and no corneal opacity is a feature of Hunter because Hunter is a male, he has to hunt. Hunter has to hunt, so he cannot have corneal opacity. So Hunter is answer. Actually, this was one question was out of that, which we have not discussed at all. We have not discussed mucopolysaccharide at all. And a 14-year-old with lancinating brain, renal dysfunction, stroke-like episode, and skin shows the lesions given were somewhat like almost similar lesion was given. Actually, for me, the options are Tay-Sachs, Fabry's, HSP, and vasculitis. After which confused was Fabry's and HSP for me. And in the image, it was very clear that those were palpable purpura. That was a thing. And the second thing is stroke-like episodes and lancinating pain. This lancinating pain is a classical feature of Fabry's that we have mentioned that painful neuropathies can present Fabry's. Along with that, the palpable purpura is that I remember like purpura looks like palpable. So palpable purpura doesn't go to HSP, so that goes to Fabry's. The answer was Fabry's. Again, we have discussed about Fabry's disease. This was a code we have discussed Febrile episode. Alpha galactosidase angiokeratoma. That is angiokeratoma diffusum corporum was what you are seeing there. Not the purpuras. Angiokeratomas were what you are seeing. It is palpable. It was looking palpable, not a non-palpable purpura of HSP. Burning pains in the hands and feet and they present in boys. R for renal, Y for young age, C for ceramide, trihexosidase accumulation, cardiovascular and stroke-like episodes. So, and corneal dystrophy. That is a code I have mentioned about Fabry's in our module on the stroke, about the classification and etiology. We have discussed about the Fabry's of one possibility of stroke. We have discussed the thalamic sign in T1 hyperintensity on thalamus because of ceramide accumulation. In MRI also we have discussed. So that was the answer for this. Okay, so that was about the peripheral nerve. There are 14 questions asked. Peripheral nerve, NMJ muscle and genetics, 14 questions asked. 4 new questions, one was rough sums. I think it was a bit answerable. Hunter also we have not discussed but not difficult because if you have gone through a little bit of MBS, Hunter was easy I think. The critical illness was very much confusing for me and CTS, NCS was also confusing. Fabry's was something which we have discussed. It was not that tough. I think these two were the very tough questions, critical illness myopathy and CTS, NCS because they had shown the NCS images and all. That is not at the MD level, that is DM level questions only. These were the 4 difficult questions which came in the peripheral nerve. So we have discussed about the major chunk of questions in the stroke and peripheral nerve. Now coming to the movement disorder and ataxia. Again, movement disorder, there is a lot of questions asked. Many are like just I told, it is all clinical. Now there are 10 questions were asked in movement disorder and ataxia. 1 question on ataxia, just very simple question, and others were like very clinical question. First question was patient complaints of rest tremors, slowness, apraxia, I think on the right hand, and right hand dystonia. This is what they recommended. So we'll just analyze it. Complaints of rest tremors and slowness. That means we have discussed that bradykinesia and tremors are classical features of Parkinsonism spectrum of disorder. So that means an extrapyramidal syndrome. But then comes apraxia, right hand dystonia. Okay, apraxia and right hand dystonia. Apraxia means a cortical involvement. So that is not a classical feature of IPD. So you have an asymmetrical Parkinsonism. asymmetrical Parkinsonism disorders includes Parkinson, classical idiopathic Parkinson disease is asymmetrical. Second is CBJD or corticobasal basal ganglia syndrome or CBJD is a asymmetrical Parkinsonism syndrome. The symmetrical Parkinsonism syndrome includes MSA, your PSP and all those things comes under symmetrical Parkinsonism disorder. But classical asymmetrical is IPD and CBGD. Again, Apraxia right hand dystonia, we have discussed in the atypical Parkinsonian syndromes, the clinical features we have discussed in detail in one session. In the hypokinetic movement disorder, the last chapter is on atypical Parkinsonism, the classical presentation of CBGD. So what do you mean is CBS or corticobasal syndrome or CBGD is a classical thing, what you are telling clinically. But the question is different. Which of the following is a probable proteinopathy? I have mentioned during the modules that I was expecting some questions on proteinopathy. I had taken a proteinopathy of FTDs in detail. Then the extrapyramidal syndromes also I had mentioned in detail. So amyloidopathy, synucleinopathy, TDP43 and tauopathy. You know that MSA, DLB, synucleinopathy includes MSA, DLB and PD or IPD. All these are synucleinopathies. Amyloidopathy is classical Alzheimer's disease. So these two are not CBS, these two are out. Then TDP43 and tauopathy. We have discussed in the atypical Parkinsonism as well as in the FTD genetics and all those things we have discussed in the FTLD genetics and proteinopathy we have discussed in separate session. They are both the chapters we have discussed it. This is from atypical Parkinsonism slide. Synucleinopathies includes PD, MSA, DLB and CBJD and PSP as tauopathies. We have discussed same thing in FTLD because FTLD umbrella spectrum includes FTD, then extended FTD which includes PSP and CBD group of disorders. So CBD and PSP both are tauopathies. So the answer here is a tauopathy. Okay, which is a proteinopathy, it is a tauopathy. Amyloidosis, it is autosomal dom, it is AD is amyloidosis. Ubiquitin proteasome disorder is PARK2. Polyglutamine disorders are Huntington disease, SCA and DRPLA. These are atypical Parkinson disorder and the proteinopathies we have discussed, trion and CJD. So the answer is tauopathy because the question has two content. First is a clinical part where you diagnose this is a CBS. Then second part is a proteinopathy. I was expecting a question on proteinopathy. So the next question is patient complaint slowness and rest tremors. That again means that extrapyramidal or basal ganglia involvement. Then since 2 years and dementia since 1 year and gait freezing and falls. So that again means that a Parkinsonian syndrome with early onset, within 2 years dementia and fall, that means early onset. So early onset is red flag signs. We had discussed about red flag signs of Parkinsonism. These are red flag signs. That means these are Parkinsonian plus syndromes or atypical Parkinsonism. Parkinsonism plus or atypical Parkinsonism. So this is an atypical Parkinsonism. They have recurrent falls. Recurrent falls favors PSP or MSA. Then there is a blepharospasm and retrocolis. Retrocolis means backward extension. That means head is held straight. And blepharospasm means eye spasm is there. And I have mentioned in the PSP gait we are discussing, I have drawn a figure also like this. PSP, the neck will be head straight, so they will have dirty tie sign. And their hands will be held like gunslinger's position. Then foot will be wide. While classical IPD neck will be bent, androcolis. Then body will be like this, hip will be slightly flexed and knee will be slightly flexed. So this is IPD posture and this is PSP posture. Blepharospasm and retrocolis are classical feature of PSP. Even without knowing that, you can tell that a typical Parkinsonism with recurrent falls is a classical feature, early feature of PSP. We have mentioned it in this slide. This is a slide from our PSP in atypical Parkinsonism. The blepharospasm, procerus sign, the omega sign, the procerus sign, the prominent upper scleral reptilian species, square wave jerks, and extended neck, that is retrocolis. All those things we have mentioned. We have specifically mentioned retrocolis and androcolis, differentiation between IPD and PSP. So this is a classical PSP. That's again a easy thing if you have gone through modules. Next question is patient's history of echinacea tremor, progressive in nature. Just some detailed history was there. Echinacea tremors, progressive in nature since last 9 years, and a stereotactic surgery is done, and image is shown below. Again, this looks like tricky question, but as a stereotactic surgery is done for a Parkinsonian spectrum disorder IPD, and the approved therapy is only DBS. And even without knowing the image, you can answer it as a DBS. And you can see the image is shown. I had mentioned in many images when we were discussing, I had shown what is subthalamus, and almost similar images were shown. Subthalamic nucleus something was there, and here in substantia nigra something was there. These are actually DBS electrode in substantia nigra. They had pointed towards arrow was put here. So that was showing was DBS electrode in STN. Levodopa infusion dip in substance. Those they are not the approved therapies. Levodopa intestinal gel is there, but the other things are not exactly approved therapy. So the answer I think is a DBS electrode in STN. And we have mentioned that the DBS treatment option, we have mentioned that STN is a best site for DBS for a Parkinson. We have mentioned the surgical treatment option, and we have mentioned about the indication contraindication. This is how you stereotactically place the lead in the STN. That is exact site where they are shown. The STN was marked, so it is a DBS lead in STN. Again, even though the question was looking confusing with the image and all, without reading the image, you can answer it because there is a stereotactic surgery which is approved only for DBS in a Parkinsonism spectrum disorder, which also we have mentioned it. Even though the image was not there, image is not needed to answering it. Next question was rather tricky, but we have discussed that also. A 19-year-old with involuntary movements, progressive rigidity and slowness. That means involuntary movements, progressive rigidity and slowness. That again means an extrapyramidal syndrome. Extrapyramidal syndrome in a 19-year-old, you will think of a genetic Parkinsonism or a metabolic cause. But the option were all genetic Parkinsonism. So the diagnosis of the case was easy. It was actually genetic Parkinsonism. Which the catch words are coming here. The improved on levodopa but developed dyskinesia. So developed dyskinesia on levodopa. The next term was also has increased tone and upgoing plantar. There's some human signs were there. Then psychiatric symptom. That is the most important word in this question. Psychiatric symptoms and no family history. No family history means it is autosomal recessive. Psychiatric symptoms is also peculiar. So coming to Park 1, the options are Park 1, 2, 15 and 6. This I remember the option exactly. These are options. Park 1 is SNCA1 gene mutation and Park 4 also same gene mutation. Park 1 and 4 are classical Parkinsonian-like presentation. They present with classical Parkinson. They won't present like these atypical features. So that is not the answer. That is not the answer. Park 6 is a PING1 gene mutation. PING1 as well as Park 2 both can present the levodopa-induced dyskinesias, which we have mentioned. This was from the Parkinsonian disorder. We have mentioned about genetic Parkinson that I had mentioned 3 slides. First slide was Park 1. Their comes under classical PD and autosomal dominant. Here there is no family history, so we are thinking of autosomal recessive. So Park 1 is not the answer. Again, they present classical PD, not this presentation. Then Park 2 is an autosomal recessive. So this is likely Park 2, and Park 2 is the most likely option because autosomal recessive. Park 6 also autosomal recessive, but it is a PING1 gene mutation. Its onset is in the 4th decade and levodopa-induced dyskinesia can present. So 4th decade, here the age is 1st or 2nd decade. So here it is 2nd decade. So young onset patient with a psychosis, behavioral problems, hyperreflexia or UMN signs, leg tremors and levodopa-induced dyskinesia. So that is a classical feature of Park 2, which we have discussed in our module. So young patient psychosis, Parkinson-induced dystonia and autosomal recessive, everything goes in hand towards Park 2. Again, this is something which we have discussed in our modules. Next question actually not exactly like this. It was somewhat similar to this, and there are a lot of them, 3-4 images were given. But whatever images given, they had shown that there was a basal ganglia iron deposition. So neuronal brain iron accumulation was given. So this question, the clue was, first thing was there is a complaints of involuntary movements and slowly progressive. And the major clue was retinitis pigmentosa was there. Second thing was this iron deposition. So you are very clear from the image. I don't remember whether there was an eye of tiger. I remember there was no eye of tiger in that image. What were given in the exam, but in the exam it was given very clearly. You can see an SW with an iron deposition. So that was enough to answer, because in the option I remember very clearly there was no other options of NBIA. There was only one option of PCAN or Pantothene kinase deficiency. And retinitis pigmentosa is a classical feature of PCAN. That itself tells the answer is PCAN. And you don't need to understand that RP is seen in PCAN in this question, because in this question image is showing a brain iron accumulation, and in the option there is only one option, brain iron accumulation. NBIA only one answer. So that is very easy to answer, even though the question looked tough. Just you understood that SW how brain iron accumulation looks like. We have discussed this brain iron accumulation. I had shown how the iron accumulation multiple times. I had shown SW images in the entire different modules. I had shown and told that SW will pick up iron deposition, and shown the image of NBA. This is the eye of tiger appearance of PCAN, classical eye of tiger. I have discussed about what is eye of tiger, other conditions where eye of tiger can occur. We have discussed this in the MCQ session on hyperkinetic movement disorder. At the end, I discussed about near the Wilson's and all, and other brain iron accumulation also I discussed. This is a slide I had shown. Pantothenol kinase deficiency PCAN is autosomal recessive. The most common beta propeller neuroferritinopathy, all those are autosomal dominant. Is only autosomal dominant is neuroferritinopathy, and only X-linked is BPAN. Others are autosomal recessive, and we have discussed about image also in those sessions. And this you can see the different clinical feature. Retinal degeneration is a feature of PCAN. Retinal pigmentary degeneration is a feature of PCAN. So that was the diagnosis of PCAN. You doesn't need to answer that question. Even the question looks tough. You don't need to know anything. You just need to know that SW there is iron deposition, because in the option there was only PCAN, which is an NBAA. Others were not NBAA. So it is easy to answer, even though the question looked tough. A patient present with history of involuntary movement since 2 years, and she tells the movement stops on touching the part of the body with her hand. So just an involuntary movement. The catch point is this thing. This is what I have discussed, specifically discussed in dystonia. The answer is dystonia. This is not a sensory trick. The chorea, it is the movement is flowing movement, non-repetitive movement, athetosecond, writhing movement, balismus, violent movement. All these are actually similar movements. Chorea, athetos, and balismus are actually similar movements. But this is a catchment. This is not a sensory trick or and this is slide from our Marrow discussion on dystonia, where I specifically told that dystonia is a pattern triggered by some reaction. Overflow is a null point is there. I told that when the patient just touches some part of the body to stop, that is known as sensory trick or just antagonist. That is what is asked in the question. When I was discussing about this, I had a confusion whether it was above MD level, because this sensory trick and all whether required or not, I was confused, but I just put it in the slide, and actually luckily that same question came by using that only. That sensory trick was a key point in this question. The answer was not difficult. It was, if you have watched the module, it is not difficult. Otherwise, it is little bit tricky because it's very clinical question. It is not MD level again, it is again DM level. That is known as dystonia. And child with the complaints of involuntary movements, associated movements lasting for seconds to minutes. That is again true. And multiple episodes per day associated with movement. So it is a movement induced paroxysmal dyskinesias. So paroxysmal dyskinesias has been divided into paroxysmal kinesogenic, paroxysmal non-kinesogenic dyskinesia, and paroxysmal exercise induced dyskinesia. Here associated with starting of movement and lasting for second to minutes. That is short duration. That is a catchword. And multiple episodes were there, and they are told the mutation also directly, PRRT2. This is associated with paroxysmal kinesogenic dyskinesia. This is the same slide where we discussed about paroxysmal kinesogenic dyskinesia in hyperkinetic movement disorder module, in tics and other movement disorder. Towards the end, I discussed about paroxysmal kinesogenic, non-kinesogenic, all those things. Paroxysmal kinesogenic associated with PRRT2 gene mutation, and this is just after the movement. Age is 1 to 20 and seconds to minute, less than 5 minutes. This is only movement which is shorter duration, less than 5 minutes. Others are lasting for hours. That itself is telling that it is paroxysmal kinesogenic. These are 2 points telling that it is paroxysmal kinesogenic. The question was which among the following is used in the treatment? Lithium, carbamazepine, valbenazine, and levodopa. Here I had mentioned anti-epileptic is used for treatment of paroxysmal kinesogenic. Non-kinesogenic sleep and benzodiazepines. Paroxysmal exercise induced, there is a ketogenic diet is a treatment. So the answer is carbamazepine. Okay, that was again directly from the module, and if you had gone through the module, it is not tough, but otherwise it is little bit indirect question, not a direct question. It is like it is coming. It is how I don't know why they are making the question very lengthy, because they are directly told that PRR2. It includes multiple things. You need to understand it is paroxysmal kinesogenic. You need to understand the mutation, then answer what is the drug for it, like an USMLE question. So next question was regarding orthostatic tremor. Which among the following is not true or false? That was a question. And gait disorder is the most prominent than tremor. Worsens on standing, improves on walking, better seen than palpated. It is 14 to 16 Hz in frequency. Orthostatic tremor is the highest frequency tremor. This is true. And this orthostatic tremor, which can differentiate from orthostatic myoclonus, both look similar. But orthostatic tremor, you cannot see it. You can palpate or you can see on the EMG. It is known as a helicopter sign. All those things we have discussed in the module. I'll show it again. So helicopter sign, it is better palpated, and patient doesn't have tremor. They will tell on standing they feel some unsteadiness and unsteadiness of gait. So gait disorder is more prominent. Worsens on standing, walking improves. While orthostatic myoclonus worsens on walking. While orthostatic tremor improves on walking. So it is better seen than palpated. This is wrong. because it is not seen, it is palpated as well as in EMG. It is not seen. So this is the answer. Better seen than palpated is wrong. We have discussed in the postural tremor session on hyperkinetic. I had drawn the table difference between orthostatic myoclonus and orthostatic tremor. I had told that orthostatic tremor is high frequency. Helicopter sign I have discussed. Orthostatic myoclonus is visible, while orthostatic tremor is not visible. And orthostatic tremor is better palpatable. And walking it increases orthostatic myoclonus, while on walking orthostatic tremor decreases. The major complaint is gait problem. So the answer was better seen than palpated. Again discussed in the module. In basal, the next question is, this was nothing, this was not discussed in our discussion, I think, in our modules. It was not, this was one question just out of the module is came. The basal ganglia deposition of which metal is associated with the gait that resembles cock walk. Cock means, this is the cock. So, it resembles cock walk. This is actually a manganese toxicity. Manganese toxicity will resemble a cock walk. Unlike your Parkinsonian gait, which is normal based and slow gait, here the gait is much faster with dystonia, which mimics that of a cock walk. That is known as cock walker's gait, seen in manganese toxicity. They walk like a cock. And this cock walker's gait, you can see the videos are there in manganese toxicity. If I think Thailand is there, the YouTube, you can watch it. They walk with, in the YouTube it is available. Just search cock walker's gait in YouTube, it will be there. You can see that it is very fast and with the dystonia, and they walk like a cock walk with the dystonia, body bowing here and there, which faster gait. Unlike Parkinsonian disorder, where it is slower gait. That is known as a cock walker's gait. Cock walker's gait is classically manganese toxicity. And which among the following is wrong for the below finding? Whatever they are given below was a telangiectasia or die. So that, and again, if you see the option, you will understand what I mentioned is ataxia telangiectasia, which is ATN gene, which is a DNA repair gene. So the following is wrong for the below finding. So DNA repair is a true statement, so that is not the answer. ATN is associated with the nystagmus, eye findings, cerebellar ataxias, and raised AFP, alpha feta protein is raised. That also we have discussed. So that is also true. This is not an answer. It is not the answer. The confusion is, you know that ATN, ataxia telangiectasia, is a DNA repair and it is associated with malignancies. So yearly X-ray screening is advised. Actually, this ataxia telangiectasia has high risk for radiation. When they respond to radiation, they will get malignancy. So they should prevent the X-rays, prevent from taking X-rays. So it should not be done. So that is, this is a wrong statement, and that is the answer is yearly X-ray screening is advised. Yearly X-ray screening is never advised because X-ray will increase risk of malignancy. So we have discussed about ataxia telangiectasia in autosomal recessive ataxias. Truncal ataxia is the first manifestation, gross motor milestones, and eye findings we have mentioned nystagmus. So nystagmus was there in the option, and elevated alpha feta protein more than 20 is the next step. We have also mentioned that. And neoplasms, dysgerminoma, breast carcinoma, gastric carcinoma, liver carcinoma, retinoblastoma, pancreatic carcinoma. There is no lung carcinoma in this group, and it has increased risk of malignancy on exposure to radiation. So radiation should be avoided in them. So that is the answer is X-ray. Even if you don't know that radiation to be avoided, it is easy because other questions were all discussed in our sessions. So that was that. So the movement disorder and attacks, there are 10 questions. Only one question was out of the MC, out of our modules, that is manganese toxicity, cock walker's gait. That only if you are gone through that you can answer. That is difficult to answer. Anytime you are heard of that, you can answer it. Okay, that was about the movement disorder and ataxia. So that was about the movement disorder. Now coming to demyelination. Demyelination, there were 6 questions were asked, and all were like ophthal and Beth papillitis and all. But there was not even a single question from multiple sclerosis. I was at least expecting a question from the drugs of multiple sclerosis. But I was expecting some questions to come from non-MS demyelination, NMO and MOG. All the questions asked were from NMO MOG. So first question was actually more or less like, you can call it as some of the questions were neuro-ophthal only. So one question was regarding bilateral papillitis. Which among the following is not true? They told the clinical finding. I don't remember what was the fourth option. The following is not true. Marcus phenomenon, normal color vision, and sequence syndrome. It is actually rather simple. It is normal color vision. So we have discussed in our module on optic neuritis. We have discussed the clinical features, RIPD or Marcus phenomena, color desaturation, centrocecal scleroderma, and RIPD. These are 3 classical findings. So color desaturation is always a classical feature of optic neuritis. So bilateral papillitis is not associated with normal color vision. So that is the answer. So this is a not true thing. So that is the answer. Okay. So coming to next question, a patient with acute transverse myelitis and fundus shows bilateral optic neuritis. What among the following is need to be sent? So it's again a very practical question which we have discussed in our MS, NMO and MOG. All the chapters I was keep on repeating again MS usually has unilateral optic neuritis, bilateral optic neuritis, a feature of NMO, MOG disorders. So again, transverse myelitis with bilateral optic neuritis, that is a clue in this question, bilateral optic neuritis. And but again, the option was simple because they are not given any more OCB or anything. They are given like CRMB, ANA, aquaporin 4 antisynthetase. So aquaporin 4 antibody need to be set. So that is actually rather very simple question, I tell. And optic neuritis, we have discussed in the NMO spectrum that disc edema and bilateral pad of fat environs are all the features of MOG. And we have discussed in optic neuritis that optic neuritis at 30 to 50% bilateral, disc edema is seen. These are features of MOG optic neuritis. Actually, even MOG and NMO both will be associated with these features. Bilateral papillitis. So the option was aquaporin 4. Bilateral papilledema and MRI shows enhancement till optic chiasma. I don't remember the exact options, and I remember like one option was aquaporin 4, next option was anti-MOG was also there. So again, I don't remember whether MRI was given or not, but it was mentioned like this. So that is a clue is again enhancement till optic chiasma. So we have discussed in NMO and MOG, I had repeatedly telling that MOG, during this MOG, were associated with anterior involvement, that is optic nerve involvement, associated with the pad of fat. This is what anterior sheath and pad inflammation. These are features of MOG. We have discussed, this is a slide of MOG when we are presenting about MOG optic neuritis, mild oligodendrocerebral associated disorder. And better recovery than aquaporin, 50% recurrence optic neuritis are MOG. And I have mentioned anterior and pad of fat. So chiasmal involvement, posterior involvement are feature of aquaporin or NMO. So the answer is NMO. Anti-GAD has nothing to do with it. So we have discussed in the MRI findings also, we have discussed in NMO spectrum, we have discussed that anterior pathway involvement is a feature of MOG, and bilateral involvement, long segment and pad of fat same. All these are features of MOG. While NMO is predominantly, we have discussed chiasma and optic tract involvement. We have discussed even the figure in the NMO spectrum disorder in the module of demyelination NMO spectrum disorder. I have put a figure where the chiasma involvement and discussed about the involvement of chiasma is a feature of NMO spectrum. So papilledema with MRI showing optic chiasma is a feature of aquaporin 4. While anterior involvement is a feature of MOG. And MS is unilateral. And case of all those things we have discussed in the module of demyelination. You can refer that. And the case of acute transverse myelitis partially responding to steroids and bilateral optic neuritis, which among the following is true? Again, they have told that it is not a typical MS. Typical MS usually unilateral involvement of optic neuritis is classical feature. Interferon is used in the treatment. Interferon is used for treatment of MS, not in the case of NMO or MOG. Steroid is used in the acute phase. Recurrent optic neuritis is very common. And actually, among the options, recurrent optic neuritis is less common. Recurrent optic neuritis is a feature of MOG. Again, it is less common. Recurrence is in NMO is more common with myelitis only. So I think the better option is a steroid in the acute phase, because acute phase treatment, which we have discussed about NMO spectrum treatment, acute phase is steroid or plasma exchange, and then followed by maintenance therapy is the treatment of NMO spectrum. So again, that means that acute transverse myelitis partial responding to steroid with the bilateral optic neuritis. The true statement, which among the following true statement is steroid is used in acute phase. Clear? That is also actually easy question, not a tough question, even though the question looks tougher. If you understood it clinically, it is a NMO or MOG disorder, then it is easy, because other treatment options, other things given were regarding an MS, I think. Okay, then patient complaints of recurrent vomiting and hiccups and imaging. Imaging is not exactly this image. Imaging was actually in this area was concentrated. It was showing a medulla and posterior part of medulla. This is like hyperintensity. So that was actually, the image was not required in this case also, because we have discussed many times. The NMO spectrum, I told that hiccups, recurrent vomiting are present of area posterior syndrome of NMO spectrum. And I specifically told that whenever a patient with a background of autoimmune etiology comes present like this, you should keep the possibility of an NMO spectrum in them, because NMO spectrum coexists with autoimmune disorder. Autoimmune disorder can later present with NMO spectrum. So the options anti-NMD, anti-MOG, anti-NMO. Area posterior syndrome is classical feature of NMO, so that was also direct question from the module. In the module, this is a slide from the module where I was discussing about the same clinical presentation, hiccups, recurrent hiccups of area posterior syndrome. I was showing the lesion of area posterior also. So that was, again, it was easy if you had gone to the module. This was little bit tricky question, little bit tougher question, but still we have discussed this question in our modules. The female present headache, subacute encephalopathy, visual blurring and hearing loss. An image shown below structure has shown black holes. The structure shown below is a corpus callosum. So corpus callosum involvement is a question. So MOG and NMO spectrum, the corpus callosum involvement is not common. Marcia Bignavi may be the first question with first option which many of you may commit. because that is something which you hear commonly during your MD days. But this is a classical presentation of headache with a subacute encephalopathy. When I was discussing about the MS, approach symptomatology of MS, I specifically told that encephalopathy is a odd symptom of MS. Whenever there is an encephalopathy, I told that vasculitis or a SUSAC should be considered, or an ADAM should be considered, headache and encephalopathy. So this was a slide where I mentioned about the rare features or the red flag signs. I had mentioned encephalopathy, seizures, headaches, all these are meningismus are not a feature of MS. And hearing loss I have discussed in this specific slide. When we discussed symptomatology, I told what is SUSAC syndrome, and I told that SUSAC syndrome is a rare syndrome where you have subacute encephalopathy with hearing as well as optic retinal involvement, because it's endotheliopathy. All those things we have discussed. So this is a classical SUSAC syndrome which affect the corpus callosal involvement. The corpus callosal involvement of the SUSAC syndrome is in the center, while MS is in the border areas where the MS is affected. This also we have discussed when you are discussing about the image of MS. So in the demyelination module, we have discussed all those things. Again, this is actually a really high funda question, but we have discussed it, and it is not that difficult to answer if I go into the module. So that is SUSAC syndrome. And we have discussed one more, 2-3 times I have mentioned about SUSAC syndrome during the module. Even though I have not taken a separate session on SUSAC syndrome, I have told specifically that it is present with headache, encephalopathy, and it is associated with hearing loss and retinal artery because of endarteritis, endothelial involvement. This I have mentioned, and I told that it is very rare, and in India only 4-5 cases has been reported. And then, so there are 6 questions in demyelination, all were discussed. So that was about demyelination. Now coming to spinal cord, there are 2 questions, and one question was little bit higher standard, the second one was easy. First question was little bit higher standard, but we have discussed same almost similar image what they have kept in this thing. The exam, we have discussed similar image. So 83-year-old with the back pain or something like that, and lower limb weakness and a sensory level at L1. So back pain and L1 sensory level, I have mentioned during the spinal cord approach, sensory level is one feature of spinal cord. So that tells you that it is a spinal cord involvement. And MRI was given, MRI was showing this arrow was also there, it was showing some hyperemesis here. And what is the investigation of choice? Even if you don't pick this MRI, you can answer if you see the option. Because option is all vascular images, CT angio, MR angio like that, DSA like that, options were there. So what they are shown is an AV dural fistula. This is the slide and the image which we discussed in our module on non-compressive myelopathy, where I discussed about the vascular causes and all, where I have been discussing about, the compressive myelopathy, the last, and I was telling about the AV dural fistula, they present in similar presentation. I told back pain followed by progressive weakness, and there will be flow voids in MRI, and I had shown almost conus involvement was there, and similar MRI was kept. They had MRI kept in the exam also, there was a conus involvement was there. So that was actually spinal AV fistula. And the investigation, the goal, what is the investigation for diagnosis was asked. The investigation for diagnosis is DSA, digital subtraction angiography. We have mentioned it in the AVMs as well as here also. The DSA is the gold standard for this investigation. So this was also partially discussed in the, you can arrive at the diagnosis, and little bit common sense you can use at the answer, arrive at the answer if you are going to the module of spinal cord. So that was again a little bit high-fi question only, not an easy question. Then vascular malformations, I have mentioned that dural AV fistula, 70% of spinal AVMs are dural AV fistula. Most common site is made below thorax, direct connection to radiculomeningeal artery and arterial system of vein. All those things we have mentioned in the modules in spinal cord only. Next question again was looking tricky, but it is very simple. The post-gastric surgery patient present with numbness, sensory loss, upgoing plantar, and other than vitamin B12, anything else will cause it. It is actually very simple. You can see that it is a present with numbness, sensory loss, and upgoing plantar. That means it is more, and other than vitamin B12 is enough to answer. It is a subacute combined degeneration. Subacute combined degeneration we have discussed that it can cause by hypocupric, vitamin B12, all those things we have discussed here in the non-compressive myelopathy. Last part I have discussed, I mentioned about the metabolic nutritional causes including vitamin B12, hypocupric, and vitamin E. All those things I have mentioned. And gastric surgery is one cause of acquired copper deficiency. That is from the medicine part. So this is a mixture of medicine plus neuro question. So the answer is copper. Okay. Again, the options itself, the question itself tells you that it is subacute combined degeneration because they are specifically mentioned that other than vitamin B12. So there are 2 questions. Both were discussed and both were answerable to an extent. So that was about spinal cord. Now coming to neuro-ophthalm, there are few questions that demyelination was overlapping with neuro-ophthalm only. So there were actually 3 to 4 questions you can tell up to demyelination neuro-ophthalm or totally overlapped. So neuro-ophthalm, frankly 3 questions. This was actually not a pure neuro question, but I put it here. This was actually a question from cardiology. PUO with a fundus picture shown below is suggestive of infective endocarditis and tuberculosis sarcoidosis. Actually, Roche spots is given, and this was an example of infective endocarditis. You all may have a tendency to write tuberculosis, but I think this was I remember this is same watermark also was there in the question paper. Same watermark of some university was also there in the question paper, and this is actually a Roche spot of infective endocarditis. It is not a neuro question, just I put it because it's a neuro-ophthalmology question. Lesion of the below structure produced which among the following abnormality? That was the next question. What they had shown is somewhat like this, and they had shown an this is they had marked as third nerve and sixth nerve, and they had shown that this is a MLF lesion. We have discussed an entire session, entire chapter on INO. 20-40 minutes I had discussed posterior INO, all those things we have discussed. So this means right eye MLF lesion. I remember it is right or left, I am sure, but it's MLF lesion. So in right eye MLF lesion means there will be right eye medial movement is restricted. That is right eye adduction restricted on the right eye, and the left eye abducting eye will have nystagmus. So that was from the option. I exactly don't remember what was exact options, but it was easy. Which one of the following is no? You just want to identify the MLF, then you can answer. Right MLF lesion was there. So actually I don't remember the exact option, but the answer is right abduction is restricted. Right adduction is restricted with the left abducting eye nystagmus. It was image shown as MLF lesion. INO, very simple INO they had put in the lesion of the image. The patient complains of diplopia and looking towards left, and on closing the left eye, the outer image disappears. This is suggesting again a pure clinical question, but the options made it very easy. So patient has a diplopia and looking towards left, and closing the left eye, the outer image disappears. That tells you that there is a diplopia looking towards left, and it is a horizontal diplopia. Why? Because he is telling the outer image is disappearing. So horizontal diplopia looking towards left side should be either a medial rectus palsy or a lateral rectus palsy. I am looking towards my left, I am having diplopia. That means either my right medial rectus is affected or my left lateral rectus is affected. Clear? So on closing the left eye, the outer image, usually the outer image is the fake images. Outer image is long. So that means that is which nerve affected? It is very simple. It is more likely to be lateral rectus. No option, there was no medial rectus only. So it was very easy. So that means my left lateral rectus or left abducens palsy. It's easy, very easy. Actually, we have discussed about the approach to diplopia. One session we have discussed. In that, we have discussed about the horizontal, vertical diplopias, horizontal diplopia, either medial rectus or lateral rectus, and the outer image will be the wrong image. All those things we have mentioned there. So that was left abducens palsy. So neuro-ophthalm, the 3 questions. One question was overlap from medicine bar cardio, which I had put it here. That was only question which was not we have discussed in our session. I just put it there because I remember that question. Infection, there was total 6 questions in neuro, and I got one question which was asked in nephro bar rheumat. So the first question seems to be completely new. Congenital severe sensory neural deficiency is associated with congenital herpes, cytomegalovirus, rubella, and toxoplasmosis. This is actually something like a direct conceptual question, a direct question, like remember, you have to remember it by heart. So only question which I felt it is a direct question. The answer is congenital cytomegalovirus infection. Then coming to the next question is again practical question. A patient complains of fever, headache and meningismus, and patient is in altered sensorium with the right pupil dilated and fixed. And imaging shows which herniation? Imaging will show which herniation. Actually, we have discussed in a meningitis segment, when you're discussing about complication, I had told that when there's a herniation, pupil asymmetry will develop. Actually, it is very simple. Even if you don't read the question entirely, right pupil dilated and with a herniation, which is same with the herniation. That means right pupil is dilated means right third nerve is affected. So it is ungual herniation. So singular herniation, upward herniation, ungual herniation is the answer. So there are different types of herniation. Transcalvarial herniation through the defect in the calvarium, or a cingulate herniation or subphalcian herniation, a central transcensoral herniation, an ungual herniation, upward cerebellar herniation, and a downward tonsillar herniation. So different herniation. So transclival herniation or transcalvarial herniation depend upon the area of herniation, which will be different. And subphalcian they present with like an ACA syndrome. Subphalcian, this is compressing the central part that is supplied by ACA. So they present with leg weakness and headache. So transtentorial or ungual herniation, the ungus come and herniate downwards and presses against the third nerve. So they present with dilated pupil, contralateral hemiparesis because of Carnosian's effect, and contralateral visual field. The upward because of the CSF, in race size, CSF is drained, sudden upward herniation because of pressure difference can occur. They present with nausea, vomiting, and obturnation because of brainstem involvement. Tonsillar, headache to brainstem compression, they present with heart rate, respiratory abnormalities in the case of tonsillar. Transtendoral herniation, bilateral dissociation, obturnation. So it is actually rather very simple. It is uncle herniation, anyone can answer it. So that was actually a simple question, even the question looks big. Then this was again a repeat question. It was asked in the previous AIMS also. Similar question was there. This is actually routinely they are asking in most of the questions. A PML, one question will come. Here there are two questions in PML. One was HIV patient present with behavioral, cognition, apraxia, and image is shown below. The image actually not exactly the same image, but this image was there in the picture. Okay, this image was there discussed in there. It was there in our exam paper. So this is something known as it was shown asymmetrical white matter hyperintensity and predominantly occipital, and there was no enhancement. And this is something known as barbell sign. Barbell sign is a classical sign of PML when it affects the parieto-occipital splenium. Actually, this is very simple. When the HIV patient comes with a behavioral cognitive problem, one option is a hand and second option is a PML. PML will be asymmetrical without contrast enhancement, while hand will be symmetrical. HIV-associated neurocognitive disorder will be symmetrical. Here was asymmetrical, and they are shown a barbell sign also. There are two signs in MRI. One is Milky Way sign, second is barbell sign. Both we have discussed in that session when you are discussing about MCQ of infection, part 1, where we are discussing about HIV, PML and all those things. Similar image we have discussed there also. So this was, but the option was simple because they had not put hand in the option. They had put multiple sclerosis, occipital stroke, and press. The answer was PML. This was a similar question we have discussed in our module. Question number 30. Question was discussed in the infection part 1 module. A 34-year-old with a retropositive patient, CD4. This was a question we have discussed. Image shown below. But in that image, we had not kept the barbell sign, but we have discussed about the barbell sign and Milky Way sign there. Then, next question was patient on interferon changing to natalizumab. Which of the following need to be screened? It's very simple question. JCV, HSV, measles antibody, and some one more option. I just put as ECG because ECG is tested for initial when you are starting fingolimod. You need to monitor ECG for 6 hours. Just to remind you that I had just put that option because I was not remembering the option. The answer is JC virus antibody. We have discussed specifically in the DMARD in disease modifying therapy in MS module, touch prescription program, and we discussed the importance of JC virus, and we have discussed one old table. The PML is a risk factor, natalizumab, so all those things we have discussed, and the ECG is monitored for fingolimod. So that was also very easy question. And patient with fever for 10 days and recurrent seizures, MRI is given below. This is also from the same image, similar image we have discussed in HSV encephalitis, and I told that to differentiate HSV from an autoimmune encephalitis will be bilateral symmetrical involvement, while HSV encephalitis involvement of insula, lateral and medial temporal lobe. The image which was shown had a lateral and medial temporal lobe swelling, and it was not a T2 image. It was shown in the image in the exam. Exam was this is a flare image. What image was shown in the exam was a T2 image, but again there was a lateral and medial temporal lobe swelling was there. Unilateral. So unilateral, lateral and medial temporal, there is no confusion. I had told multiple times during HSV as well as an autoimmune encephalitis. That is one point differentiating HSV encephalitis from autoimmune encephalitis. And so it is a 10 days fever, recurrent seizures. It was HSV encephalitis. So option was regarding the treatment. CSF and start on ATT. I start on IVIG, steroid and antibiotics, CSF and aceclofenac. So the answer is CSF and aceclofenac. Why not autoimmune encephalitis? Autoimmune encephalitis is usually medial temporal only and bilateral symmetrical. And this is the image from we were discussing about HSV. I had told specifically that lateral temporal plus medial temporal asymmetry are the features of HSV encephalitis when compared to autoimmune encephalitis. So next question was, even the question was looking very difficult, but when you read the question, it's very simple. They had shown that a pyramidal cell of medulla was showing eosinophilic inclusion from a patient which has features suggestive of GBS and died of respiratory failure. So that means acute flaccid quadriparous and died of respiratory failure, and the medulla, the medullary cells, the cells in the biopsy are showing eosinophilic inclusion inside. This is actually very easy because we have discussed the DD of GBS. One is rabies. This is actually directly rabies. It is a dumb rabies which was with the flaccid quadriparesis with eosinophilic inclusion. That is a negri bodies, which is shown in the negri bodies. Actually, even though the question looks difficult, Even without the image, you can tell it. There's no need of image in this because they had explained the details of image in the question only, and they are told that features suggestive of GBS. That was enough to tell that this is a Negri body. Okay, because you are not expecting anything to happen in GBS in the brain. So 6 questions, 2 were not discussed, CMV and herniation, but herniation was very much answerable. CMV, I think some of you might have able to answer, not a difficult question, but it was something which we have not discussed in the module. So there was altogether 1 question was difficult to answer. Then coming to dementia, there are 8 questions on dementia, and almost everything was discussed during the modules. First question was alcoholic patient present Wernicke psychosis, and which of the following is atrophy, which of the following structure atrophy is seen. And this similar question came in the AIIMS also. Olivary nucleus, thalamus, mammillary body and amygdala. We have discussed in this is a module when we were discussing about the circuits of memory. The last part I have told I had drawn the pappus limbic circuit and told that Wernicke's affect the mammillary body. So the mammillary body atrophy is a feature of Wernicke-Korsakoff psychosis. Initially hemorrhage, later atrophy. Anterior thalamus also can be affected, but classical involvement is mammillary body. In a Wernicke's encephalopathy, which of the following investigation is used? This is something which we have not discussed, and it is there in Harrison. It is a question from Harrison actually. RBC transketolase can be used for diagnosing thiamine deficiency of Wernicke's. The other options I am not remembering. So the answer is transketolase level. It is also actually direct question. This one question, there are 2 questions, one is CMV and these 2 are 2 questions directly came, and I think this was directly from Harrison. Patient has a progressive dementia since last 3 years, which of the following is test is not required. We have discussed about the correctable cause of dementia in the approach to dementia as a code with dementia. D for drugs, E for eye and ear, M for mentation or depression. Next E for those things we have discussed, infections, all these things we have discussed. And we have specifically told that B12 and TSH are emergency required. And even if you don't know the entire thing, just go to the history, 3 years history, imaging anyway it is required. So you cannot tell that. B12 and TSH is a basic investigation for dementia. CSF analysis is something which is required if the progression is fast, otherwise it is not required. Or the progression with a feature suggestion of raised ICP, then you should do a CSF analysis. Otherwise, CSF analysis is not a must. So in the Bradley, it is not mentioning CSF is a must. Bradley telling all dementia patients vitamin B12 and TSH should be tested. Okay. So again, the clue from the question, even if you don't know anything, the 3 years of progressive disorder with dementia, imaging vitamin B12 TSH anyway you have to do. That everyone knows it. The 4th option, the CSF analysis may not be required. The 3 years TB or chronic infection might have progressed much more worse than this. Okay, so the answer was CSF analysis. The patient with progressive memory loss and FDG PET shows decreased uptake of temporoparietal and posterior cingulum. Which of the following is possible? This is again a hi-fi question, DM level question. But luckily, we have discussed this question. Options are DLB, AD, FTD and MSA. So this is where I have discussed about SPECT and PET imaging in the case of Alzheimer's disease. I told that Alzheimer's disease, AD dementia, you can see that hippocampal posterior cingulum and temporoparietal area, all these areas will show hypometabolism. The question was temporoparietal and posterior cingulum. Same question came. And why I told it, I shown the image also, I shown the parietal, temporal and medial temporal, posterior cingulum, all these areas had marked in the slide also. Why this question came? Because this is a slide from DLB. DLB, it is difficult to differentiate from AD in imaging. The thing which can differentiate is a cingulate island sign, where the posterior part of cingulum, parietal, all these areas will be affected. Well, the parietal lobe and temporal lobe, temporoparietal will be affected, but the singular area will not be affected. So singular area which is not affected will stand out. This posterior singular area will be unaffected. The metabolism will be normal in the posterior singular area in the case of DLB. So that sign is known as cingulate sign. When I was taking the class, I told this is a possible question, cingulate sign. They have indirectly asked a cingulate sign because the question was temporoparietal plus posterior cingulum. Temporoparietal plus posterior cingulum involvement, hypometabolism, posterior cingulum is a feature of Alzheimer's disease. Temporoparietal without posterior cingulum is a feature of DLB. So the answer is easy now. It is Alzheimer's disease. FTD frontal and MSA brainstem and cerebellum is hypometabolism. That also we have discussed in FTD and MSA, atypical Parkinsonism, neuroimaging modalities. I was expecting some question to come from neuroimaging modalities. That is why I put the images as well as cingulate island sign In the all these things I have put because of that. Then coming to the next question, the patient presents history of behavior and personality changes, memory is completely preserved. An MRI shows some tumor, what is the possible location? This is also a very practical question but easy one. I have told that medial temporal lobe is there, medial frontal lobe is there in the midline, then dorsolateral prefrontal lobe is there, and you have an orbitofrontal cortex. This is the left side. This is, suppose this is a one side, there is a medial frontal, dorsolateral prefrontal, and orbitofrontal. Dorsolateral prefrontal executive dysfunction. Medial frontal energization, apathy, abulia, all those things we have discussed. Orbitofrontal present with behavioral and personality. And behavioral and personality can also be affected when there is a amygdala hippocampal involvement. But when there is a medial temporal lobe amygdala hippocampal involvement, memory will be affected. So dorsolateral prefrontal is associated with executive dysfunction. So that is not the answer. Amygdala will produce seizures or memory disturbance, fear response, all those things. Hippocampal again medial temporal lobe structure. So these will be associated with memory loss. So the structure which present with behavior and personality changes without memory loss is the classical orbitofrontal cortex. We have discussed in the image, that is reward pathway, how it is affecting and loss of apathy, social decorum, manners, all those things, behavior and personal, all those things we have discussed. And in the FTD, behavioral and FTD, there is a criteria we have mentioned where there is relative sparing of memory and visuospatial is a feature of FTD because medial temporal is unaffected. So again, that is indirectly asked here in the question. It is actually a simple question. The next question is a patient with NPH, which among the following is not true? In all the examination, one question will come from NPH and one question from PML. Similar question came in AIMS also. I mean, AIMS, not AIMS, INACET this time. And the options were actually, it's actually very simple. MRI shows ventriculomegaly with atrophy, that was one option. CSF test will improve the symptoms. And the triad of gait, urinary incontinence and dementia, VP shunt will improve the symptoms. Actually, you all know that the NPH, the most confusing thing is with ventricular atrophy. So, when extract dilatation of ventricles or NPH, that is a confusing thing. So, this option is obviously wrong. So, that is the answer. MRI shows ventriculomegaly with atrophy. In NPH, ventriculomegaly will be there without atrophy. That is a feature of NPH. With atrophy, it is extract dilatation of ventricles. And CSF tap will be improved symptoms, that is true. Triad is true, and VP shunt will the treatment of NPH only. So we have discussed about NPH in detail in other dementia. In dementia module, the last session, other dementia, we have discussed the NPH findings, Evans index, temporal horn dilatation, periventricular seepage, callosocceptal angle, all those things we have discussed in detail. And this was the image which we have discussed. So just to tell you that in NPH, what happens is inside the ventricle, the pressure inside the ventricle is going to increase. The pressure inside the ventricle is going to increase, and this will push. So this angle is known as the callosocceptal angle. This angle is known as callosocceptal angle. This callosocceptal angle, this is the ventricles. Okay. The ventricle and the pressure increases, this will push the callosocceptal angle like this. So callosocceptal angle became acute and you won't see any atrophy here. While here in extract dilatation, as the atrophy increases, ventricles will goes downwards. Ventricles will push downwards because the brain is parenchyma is atrophied. So the angle of the callosocceptal angle will become more wider, clear, and you can see atrophy here. This is not the importance of callosocceptal angle. This is a major thing which differentiate an extract dilatation from NPH. Whenever atrophy is there, atrophy is not there. So that is a very simple question. So next question, a patient with Down syndrome, now age of 44 years, cognitive worsening, which among the following genes in chromosome number 21 is responsible for cognitive deficit? Actually, it is almost everything is told in the question only, and we have discussed it directly. It is directly from the module. We have discussed it also. APP gene in chromosome 21 is responsible for one genetic cause of Alzheimer's disease, and the same chromosome 21 mutational trisomy will result in Down syndrome. So that is why Down syndrome patient, when they grow old, they will develop into Alzheimer-like dementia. When there is a cognitive deficit, not associated Down syndrome. This patient has a cognitive defect which is not amounting because of Down syndrome. So the answer is APP gene. Okay. We have discussed in our module, genetics of Alzheimer's, we have discussed in detail. Early onset autosomal dominant, early onset genes, autosomal dominant genes, APP gene, chromosomal 21, and dyscalculia I have mentioned also that same gene is, that is a reason for Alzheimer-like presentation in Down syndrome. We have mentioned that also in the slide. You can refer to that area. Then, next question is a female with memory loss was asked to show how to brush the teeth, and she finds it difficult to do, and later she does it with her finger with spatial errors. This seems easy question, but there is high chance of getting confused. So here, we have discussed a module or separate section on apraxia and on praxis. So, ideomotor, ideational, conceptual and dissociation. These are the 4 options given. So, ideomotor and ideational. In ideomotor apraxia, when each single individual step will be affected, they cannot do individual step and they will do with spatiotemporal errors. Okay, so these errors of ideomotor apraxia can be object errors or spatiotemporal errors. So here when he is asked to show with the brush, he is unable to do. But when he does it with fingers and he makes spatial errors. So that means spatial error is there. So that means that his sequential action is not that much affected, but he is unable to do with spatial errors. So that means this is able to do with finger but unable to do with object, and there is a spatial error. That means that the object association is gone, a plus spatial error. Understood? So he has said object association gone and spatial error is there. So in ideomotor apraxia, same slide from our discussion, ideomotor apraxia, there will be spatiotemporal errors and internal as well as external errors. Those errors include object association error. They cannot associate the object with the action. Okay. In ideational apraxia, they are able to understand the object. They are able to do individual tasks. They will be able to place the paste on the brush, but they will be unable to do after that. If they are given a brush, they will be able to place the paste on the brush, but the next sequential action they cannot do. Here, he is unable to do with the object, but with finger he imitated it. That means that object knowledge is lost. Again, they had mentioned, I remember that they had mentioned a spatial errors also there. So that means that it is not an ideational apraxia, it is ideomotor apraxia. Many will go and tick it as ideational apraxia. So it is an ideomotor apraxia, I think is a better answer. And conceptual and dissociation has nothing to do with. Here, sequential action is not that much difficult if you are affected. One thing is there is spatiotemporal, that is a classical feature of ideomotor apraxia. And second thing is there was an object association error that also occurs in ideomotor apraxia. Sequential movement is unaffected. He can imitate it with without a brush. With the brush, usually the apraxia is normal. If there is ideational apraxia, they can do it better. But they will have unable to do in the sequential action. Here, without brush, they are doing the sequential action. But when the object is given, they have confusion. So I think it is better option to be ideomotor apraxia because it is an internal configuration error and spatiotemporal errors. These are 2 features of ideomotor apraxias. All those things, I think, not about internal conflicting errors, but I mentioned the spatiotemporal errors and sequential action. All those things in the apraxia module, we have discussed how the gas, the reach movement, grass movement, all those things affect and how to differentiate. Also, we have discussed. So dementia, there are 8 questions. One question which is out, which is transcetolase, which is directly from Harrison. Now coming to epilepsy, there are 2 questions asked, both were easy and both were image based. I was expecting more questions on epilepsy, but it didn't came. So the first question was a 14-year-old with a recurrent fall of objects in the hand and EEG was shown below. EEG was somewhat like this, not exact, somewhat like this. It shows a generalized discharge. So you can understand that a generalized epilepsy, actually even without the EEG you can answer it. Because as recurrent falling of object in a 14-year-old likely to be myoclonus. Likely to be myoclonus. And the options also is telling about benign condition, sodium valproate. So you can directly tell that it is a juvenile myoclonic epilepsy. There is no need of EEG in this case actually. Even without EEG, you can, if you do little bit common sense, you can get the diagnosis. So options are condition causes refractory epilepsy. Condition is benign, doesn't need treatment. Sodium valproate is a treatment needed for treatment for 2 years. Patient requires lifelong treatment. So condition usually doesn't causes refractory epilepsy. They will cause epilepsy which requires lifelong treatment. So that is wrong. Condition is benign and doesn't need treatment. Never. Condition is benign generalized epilepsy as a term previously used, but it is not benign completely. So now it is not used. Idiopathic also not used. Genetic epilepsy is a newer term. Genetic generalized epilepsy is a newer term. So that is wrong. Sodium valproate is used needed for treatment. That is correct. You given for 2 years. That is wrong. Lifelong treatment is required for primary generalized epilepsy. We have discussed in JME in a primary generalized epilepsy. We had put a separate chapter in epilepsy module where I had mentioned JME has myoclonic jerks on awakening in 100% of cases and 6 to 25 years is age is 6 to 25 years. Here the patient age is 14 years. And I have drawn and mentioned about the pattern of EEG discharges and treatment. I have mentioned that lamotrigine, valproate, all those things can be given and lifelong treatment is required. So that is directly from the we can answer if you know just some common sense. Even without EEG, you can tell that it is a. We have discussed and we had shown the EEG also. We had taken a separate session on EEG also. Okay. So that was it. Next question is actually almost similar question we have put in the MCQ session on autoimmune encephalitis chapter. I put a question, almost similar question game. A female with seizure behavior problems, perioral involuntary movement, CT abdomen shows ovarian mass and EEG given below. Even though without knowing the EEG, you can answer this. Again, this EEG was not needed for this question. EEG was showing delta waves with beta activity overlaying that is known as delta brush, extreme delta brush. Okay, even if without knowing that, you can answer that because the behavioral problems and perioral involuntary movement is classical for NMDA, and they have shown that CT abdomen shows ovarian mass. What else is needed? So the answer is anti-NMDA encephalitis. We have discussed similar question in our module on MCQ on autoimmune encephalitis. 30-year-old female present behavioral issues, decreased or psychiatric manifestation followed by seizure and encephalopathy, and they had shown an image of delta brush also. So similar image, similar question game. So it was also answerable. 2 questions, both were discussed. So there were some questions from the miscellaneous questions which comes from some areas outside neurologism, medicine related questions which we have not discussed, and some sleep questions. There is only 1 question came from sleep and say 5 questions from other areas. And the sleep question was actually not exactly from neurology, it was more from Harrison. A patient complains of excessive daytime sleepiness, snoring, awakening from the sleep, and BMI of 31, and postprandial blood gas analysis shows carbon dioxide of 55 and SpO2 of 90. So here the options given were obesity hypoventilation syndrome or OHS, and OSA, obstructive sleep apnea, central hypoventilation. 1 more option was there. Anyway, central hypoventilation is, you all know that the central hypoventilation is not the answer. The confusion was narcolepsy, as I put the option as narcolepsy. Confusion was between OSA and OHS. Confusion that may comes between. So we have discussed in our module on sleep disorder of respiration, sleep disorder 2, hypopnea, apnea, and AHI, RERA, all these are the diagnostic features. Especially AHI is important. They have not mentioned anything about AHI. They had mentioned only awakening, snoring, and sleep, excessive daytime sleep. That doesn't make you diagnose of OSA. For diagnosis of OSA, you need to have an AHI index. All those things need to be given. So it is less likely to be OHA. And I have mentioned about upper airway resistance syndrome. They will have snoring with recurrent arousal and apnea. That is what sleep medicine tells us, upper airway resistance syndrome. In Harrison, the definition of obesity hypoventilation syndrome is a BMI more than or equal to 30 and a chronic daytime alveolar hypoventilation with excessive daytime sleepiness and a PCO2 more than 45 at sea level during daytime. Okay, here you see the BMI is more than 31, postprandial blood analysis, that is morning blood analysis, it is more than 45. So that is diagnosis is obesity hypoventilation syndrome. It is a rather simple question because you all know that for OSA diagnosis you need to have AHI index, all those things are not mentioned, and the patient is obese, so likely to be obesity hypoventilation syndrome. This was 1 more question. It is actually more of medicine question. Hypernatremia is not associated with cerebral salt wasting, ICH, CVT, SAH. Cerebral salt wasting, you all know that it is associated with hypernatremia. So the answer is hyponatremia. My answer is cerebral salt wasting syndrome. Raised ACP will produce hypernatremia, ICH, CVT, SAH all produce raised ACP, and that causes brainstem compression or something which present with hypernatremia. That also you all know. So that is actually a simple question. Cerebral salt wasting is the answer. So that question was rather easy. It was not a pure neuro question, but it was rather easy. Then a patient present paraplegia and some sensory level they had mentioned, and CSF was done, which is shown this similar figure, almost I think same figure is shown. You all know that it is a Cobb formation and the answer is Froehn syndrome. It is also not that tough question. It was something which we have not discussed, but it is not tougher question. It is Froehn syndrome. The answer is easy. Excessive protein producing coagulation in the test tube. It is classical. GBS was 1 more option. Another options I am not remembering. MOG was also there. 1 more option was there. But the answer was very easy. Patient admitted with hyperglycemia and sodium of 112 and was treated with insulin infusion and 3% saline. And patient developed a paraplegia, pseudobulbar signs, and serum potassium of 2.9. What is the possibility? Here, the answer is actually not that difficult because so potassium was hyponatremia was only confusion. Hypokalemic periodic pulse might have the only confusion it comes. But here, sodium was 122, 112 in hyperglycemia. When the patient is in hyperglycemia, you may have a pseudo hyponatremia. So the exact value may not be 112. So if you correct it to 3% saline, the overcorrection might have happened. And the catch point here is a pseudobulbar sign. Pseudobulbar sign cannot occur in a lesion in the peripheral muscle or nerve or something, all those areas. So that means that he has bilateral corticobulbar sign involvement. So you have a bulb, that is a brainstem, and you have the brain. Okay, this is a bulb. What do you call it as bulb? So if it's a bulbar palsy, that is known as brainstem involvement, that will be LMN palsy. But when you have fibers coming from the cortex descending to the brainstem nucleus, that is known as corticobulbar fibers. These corticobulbar fibers are damaged bilaterally. They may present a syndrome which mimic a bulbar involvement, but this is actually a UMN lesion. This is known as pseudobulbar palsy. So pseudobulbar palsy means bilateral corticobulbar involvement. So this means that you have a background of hyponatremia which might have been a pseudo-hyponatremia which is overcorrected. So the answer is osmotic demyelination. Again, doesn't needs much knowledge, just needs to have a common clinical sense to answer this question. Again, they keep on asking lot of clinical questions in this session. Then next question was actually a very difficult question. I will say I didn't know the answer. I had to search in net to find out the answer. A 3-year-old infant with hearing assessment has been done by PTA, play audiometry, visual reinforcement audiometry and behavioral audiometry. I initially thought the visual reinforcement audiometry might have been the answer, but I went and find out the answer is play audiometry. This is because newborns evoked acoustic emission or auditory brainstem response. Your BERA, all these things are used for newborn. But for toddlers, play audiometry and visual reinforcement is used. Visual reinforcement is used up to 2 to 6 years. 2 years to up to 4 or 5 years, what you use is play audiometry. So in the 3 years, play audiometry is the best. For older children, PT and tympanometry is used, 4 years or 5 years above. So for toddlers, it is a 3-year-old. PTA used for older children. Play audiometry used up to 3 to 4 years. You can use play audiometry in toddlers. Visual reinforcement up to 6 months to 2 years. And behavioral audiometry, what is that? Behavioral audiometry is a screening test of babies to watch their behavior response to certain sound. It is a screening test. It is not a diagnostic test. So that is also not the answer. So infant with a 3-year, the best option is a play audiometry. So newborn, your BERA or auditory brainstem response or evoked acoustic emissions are used. For toddlers, play or reinforcement, visual reinforcement up to 2 years, but play audiometry can be used up to 3 to 4 years. 4 years above, you can go with pure tone audiometry and tympanometry or impedance tympanometry. And behavioral audiometry is as a screening test. Play audiometry, a test that uses electrical machine to send sounds at different volumes and pitches into your child ears. The child is often wear some type of headphones, and the test is changed slightly in older age group and made into a game. And this type of, you don't need to go into the details, just understand this much is enough. Newborn, it is ABR or EOA, and toddlers, it is play audiometry or visual reinforcement audiometry. In older children, more than 4 or 5 years old, you can go with PT and tympanometry. So there was one more question which I didn't remember the options and the entire question. So I know the structure of the question. I just made a structure and I want to discuss the topic. That is why I just put the question there. A child, I think it is 3-year-old child with a non-reversible coma, which among the following is true to declare brain death? And I think the option 1 has containing 2 examinations done 12 hours apart, and 1 was containing 2 examinations done 24 hours apart, 1 was single examination. I remember like that. So we will just go into the assessment of patient with brain death. So the prerequisite for a brain death evaluation, all the reversible causes must be ruled out. Coma and irreversible coma should be there, and irreversible non-cause should be there. And neuroimaging should explain the coma. And sedative drug effect is absent. No residual effect of paralytic drug. Absence of severe acid-base electrolyte or endocrine abnormality which explains the coma. And no or near normal temperature. That is the core temperature more than 36. Hypothermia should not be there. A systolic blood pressure should be more than 100. Hypotension, severe hypothermia, all those things should be avoided. And no spontaneous respiration. All those things should be there. A coma, basically, this prerequisites means a correctable cause should not be there. Sedative drug, hypotension, hypothermia, a sedative drug, or a muscle relaxant. If at all it is given either a toxicology panel or 5 times half-life should be over. And the coma should not be explainable by other causes. All those things should be the prerequisite for that. If all those things are fulfilled, then go and examine. What all things you should examine? You should examine a pupil to see that it is non-reactive to bright light. typical mid position between 5 to 7 millimeter. A corneal reflex is absent. Use both saline jet and tissue touch, and eyes are immobile, and oculocephalic reflexes are absent. Oculovestibular reflex are absent. That means brainstem reflex are totally absent. Your corneal reflex, your pupillar reflex, oculocephalic, oculovestibular by using 50 ml of ice water in each ear separately, and no facial movement to noxious stimulus at supraorbital nerve, temporomandibular joint compression, absence snout rooting reflex in neonates, and gag reflex is something is different for young child, and gag reflex is absent, cuff reflex is absent, no motor response to noxious stimulus in all four limbs. That means no motor response, no brainstem response. Clinical findings not compatible with brain death are nystagmus or spontaneous eye movements. Conjugate eye deviation should not be there. Pinpoint pupils are not associated with coma. It should be 5 to 7 millimeter, mid-dilated, non-reacting. And grimacing to noxious stimulation and decerebral decostric cortical post, no response to deep pain should be there. And after all these prerequisites and examination are met, then you do an apnea testing. Apnea testing, patient should be hemodynamically stable. That means a blood pressure more than 100 and prerequisite of a temperature more than 35 degrees should be there. And ventilator adjusted normocapnia, you should draw a ABG prior to apnea test, and PCO2 should be 35 to 45. 35 to 45 PCO2 in prior to doing an apnea test. Prior to apnea test. And then you give oxygenation. 100% oxygen for 10 minutes. And how will you give? You will put through the ET tube and put into the carina. You should give through the carina at pre-oxygen 100% oxygen for 10 minutes. And patient maintains oxygenation with a PEEP of 5 centimeter of water. And then you disconnect the ventilator. No, initially you should give 100% oxygen, and then you disconnect the ventilator. Then you keep an oxygen via the nasal in the catheter, and at 6 liters per minute, or attach the TPs either in the carina or attach the TPs or CPS or EPS valve, 100% oxygen, then switch off the ventilator or remove the ventilator, then give oxygen at 6 liter per minute into carina through the ET tube, and then you will assess for 8 minutes, 8 to 10 minutes you will assess, and no respiration or respiratory drive or effort should be there, and arterial blood gas taken at 10 minutes or 8 minutes later, and then reconnect the ventilator. If the arterial blood gas, initial blood gas carbon dioxide was 35 to 45. After this apnea test, the carbon dioxide PCO2 has built up to 60, and PCO2 hypercapnia is the biggest stimulator for respiratory syndrome. So even if when the hypercapnia is built up to 35 to 60, almost doubled, the patient is not getting respiratory drive. That means he is brain dead. That is why you are taking a PCO2 after apnea test also and before apnea test, or at least 20 millimeter rise in the normal baseline value. Okay, if apnea test cannot be done or aborted, then you can go with other tests like EEG or cerebral blood flow. No need to go with apnea initially. Apnea test, if no, apnea is the first test to be done. If not able to do, then go with. So apnea test, first you should take a blood gas, see the PCO2 is 35 to 45. Give 100% O2 to the ventilator for 10 minutes, then remove the ventilator, put the catheter or the oxygen catheter into the carina and give 6 liter per minute oxygen for about 8 to 10 minutes. And after 8 to 10 minutes, draw ABG and reconnect the ventilator. And with the PCO2 increase of 20 millimeter up to 60, and it is unable to generate respiratory drive, that is enough to tell that patient has apnea test is positive. So, how much time you should repeat it? For a newborn, more than 37 weeks of gestation to 30 days, that is within 1 month, 2 examination in 2 separate physicians, 24 hours apart. For this was there in the option. Newborn, 2 examination by separate examiners at 24 hours apart. But for a 1 month to 18 years, less than 18 years and not a newborn, again 2 examination but separate by 12 hours. For more than 18 years, 1 examination is enough according to US. So that was there in the options. I exactly don't remember the exact options there, but I just want to tell you that basically before declaring brain death, you should confirm. The first thing to confirm is reversible causes are not there. Reversible causes are not there. Imaging wise or examination wise, hypothermia, hypocapnia, drugs or nothing should be there as reversible cause should be excluded. Then examination is directed against brainstem reflexes, pupillar reflex, corneal reflex, your oculocephalic reflex, oculovestibular reflex, and cuff reflex. Then you will do the pain grimacing or no movement, no response or no motor response to pain should be there. All those things are completed. Then the third step is apnea testing, which we have explained. Apnea testing, you should measure PCO2 before and after. Before apnea, it should be 35 to 45. Then give 100% oxygen for 10 minutes. Then remove the ventilator, connect the tube into the carina, give 6 liters per minute. After about 8 minutes, and check a ABG, and if there is no respiratory or no response in the patient, and a hypercapnia of up to 20 millimeters from the baseline or 60, more than 60, is unable to make the patient respiratory drive. That is known as brain death. And for newborns as well as less than 18 years, 2 examinations to be done at a gap of 24 hours in the case of newborn and 12 hours in the case of less than 18 years, and more than 8 years, 1 examination is enough. So that is the apnea testing. And there was 6 questions, and 2 questions was like out of the box. One was brain death, and second was about the 3-year-old with the APTA, which were not discussed in our modules. And there was one more question which I didn't get the options. This was asked not in the neuro paper, and I didn't see this question in neuro paper. This question was asked in some other paper, maybe in the nephro or rheumat. HIV patient CSF shown below, and what is the treatment of choice? Actually, this is a cryptococci in the CSF in HIV patient. We have discussed about the treatment of cryptococci in HIV as well as non-HIV patient in detail in the session on infection about MCQs in infection 1, I think, where I had told that induction phase of liposomal amyloidosis and flu cytosine. In the case of a immunocompromised, it should be given for 4 weeks, while a normal patient for 2 weeks, and then a consolidation phase of 400-800 mg for 8 weeks, where it is different for immunocompromised as well as healthy patient. I don't know exactly what are the options asked, so this was a question just asked in not a neurology paper. So as of all, there are 70 questions we should find. I was able to recollect, and out of that, 1 question was not a neuro, so 69 question gave the neuro paper. And stroke, there were 12 questions, 4 questions were out of something which was expected, of which SDH anyone can answer even without knowing much details because the question was simple. But AVM, there are 2 questions, and dural AV fistula, I feel they are very high standard questions and difficult to answer questions. And in peripheral nerve and muscle and energy genetics, 14 questions, 4 questions, one was rough sum, which was easy to answer. Rough sum, I feel it was little bit okay to answer. And CTS and NCS, okay, even if without NCS, you were able to at least arrive at some diagnosis, but it was still difficult. Hunter and critical illness, Hunter, I think if you have gone through it, you can be able to answer, but I will feel it as a slightly tougher question. And critical illness was myoneuropathy, exact answer also I don't know, an exact question also I didn't get, but that was a really tough question and a really difficult question even for DM. And the moment disorder and ataxia, 10 questions, one was manganese toxicity co-coccus gate was asked. That was only question which came out of the box. And demyelination, there were 6 questions already discussed. Spinal cord, 2 questions both were discussed. Neurophthal, 3 questions. 1 question which was not neurology, and that came from cardiology, which was endocarditis fundus. That was something which I have not discussed because it comes under cardiology. And infection, there are 6 plus 1 question in the non-neuro paper. 2, that is CMV infection and herniation. These 2 were difficult questions, and herniation was actually easy to answer because it was, even though the question looks complicated, it was easy to answer. And dementia, there was 8 questions, only 1 question, that is transketolase, which is directly from Harrison, was something which is out of the box. Epilepsy, there are 2 questions, I was expecting more questions, and both were discussed. Miscellaneous and sleep, there are 2 questions, one was brain death and one was audiometry in a child. These are 2 questions which are out of the box. So total out of the 70 questions, I feel 15 questions were slightly out of our modules. Of the 15 questions, I feel 2 plus 3, 4, 5, 6, 7, 8, 9 and 10. Like 10 questions was, I feel it is maybe difficult, really difficult to answer. Altogether, around 80% questions you will be able to answer if you have gone through the modules from whatever questions asked. And among the Marrow modules, I had taken some 18-19 modules. Approach and language, actually I was not expecting much questions in that area. That was an introduction. And sleep, only 1 question came. That was little bit unexpected. I was expecting some questions from narcolepsy, and I was expecting some questions from sleep drugs because they are newer drugs that didn't ask. That was unexpected. Peripheral nerve, 10 to 12 questions asked, including muscle also. There are 14 questions. They were all like good area of coverage, and peripheral nerve, almost all areas were touched. And muscle, there was only 1 question. I was expecting some questions from SMA and DMD, But DMD question came, but SMA, I mean not from SMA, the treatment of DMD and drugs I was expecting also inflammatory myopathy. So almost every time inflammatory myopathy one question will come. These two questions didn't come. That was the question I expected. Neurophthal and cranial, a lot of questions came from the neurophthal and I was expecting a lot of questions. That is why I put a separate module of neurophthal also. And all were answerable if you have gone to the modules. And dementia, 8 questions asked, and dementia also I was expecting some questions, and except one RBC transcatalase, all were discussed. Stroke, 14 question, whatever is exam, stroke is the most important topic. That is here also it is true. And but the questions unexpected for me was AVF, dural AV fistula, AVM and SDH, but SDH was still answerable. The AVM and AVF was difficult for me also. And epilepsy and EEG, there are 2 questions. I was expecting more questions. I was expecting question from AED, anti-epileptic drug, but that was not asked. That was something which I was not expecting. But I think the coming exams, these areas questions will keep on coming. Narcolepsy and AED, there were questions in last INA CET also. So, and even treatment of DMD, all those areas are usually asked. Newer drugs are not even a single drug was asked. And headache, no question. That was totally unexpected for me. I was expecting at least 1 or 2 questions from headache, because all exams there is 1 question from headache. Here 1 question came from headache was with AVM. And demyelination all from non-MS. I was expecting questions from non-MS only. And I was expecting at least 1 question from MS, but no question came from MS. But it was all from NMO spectrum and MOG disorder. But luckily all were discussed. And cerebellum and ataxia only 1 question. That was actually a very simple question, not a difficult question. And neuroinfection 7 questions. CMV herniation 2 questions which came out of the box. Otherwise it were PML, all those things were expected questions only. Spinal cord 2 questions and both were okay. And M and D, again I was expecting some questions from SMA per se. There was no question came from SMA because SMA drugs were there in the hype in the newspapers. But SMA drugs was asked, two questions were asked in INA CET this time, but no questions came. That was unexpected for me. NMG and channelopathy, only 2 questions. I was expecting at least 1 question coming from channelopathy, but there was no question came. And the most shocking thing for me was I was expecting at least 1 question from drugs, at least somewhere from MS drugs or anti-epileptic drugs or SMA or DMD, newer drugs, or aducanumab, which is newer drug for Alzheimer's. They had not touched the drugs only. Entire question, but not even a single question from neuro drugs. It is very unlikely to happen in usual exams. Usual exams, at least 1 or 2 newer drugs questions will come. So altogether my analysis was same only. Lot of core neuro questions, lot of clinical questions. There will be time management will be difficult and lengthy questions. You will get confused with reading the questions, but all questions had a hint or a clinical clue was there. That clue, if you catch, you can answer even without reading the entire questions. So I feel the paper entirely was not easy, and it is a little bit higher standards than last 2-3 years NEET exams, and lot of core neurology DM level questions came, especially when they asked lot of core neurology questions in non-neuro subject. It is difficult. So that was the analysis and review about the exam, and you can suggest me either in Facebook of Marrow page or in the comments or the Marrow mail. You can send any. I'm not sure about all the questions. I'm not sure about all the options. In fact, after reading those lengthy questions, it was very difficult for me to by heart it, and I collected from some of my students as well as with whatever I remember. I wrote it up soon after the exam, but still it is incomplete. Some areas I was not remembering properly because there is a lot of neuro questions and all are difficult questions. Okay, that's all. Thank you. Hope you all have done at least well, and hope that this exam, I think that this exam, the cutoff mark will come down. Thank you.